بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف الخلق أجمعين وعلى آله وصحبه والتابعين. سعادة رئيس الندوة الأستاذ حسن بن عبد الرحمن البهكلي، مدير عام ملتقى الخبرات لتنظيم المعارض والمؤتمرات. سعادة الدكتور أشرف أمير، رئيس اللجنة العلمية لهذه الندوة. أصحاب السعادة الأساتذة المتحدثين في هذه الندوة من المملكة العربية السعودية ومن جمهورية مصر العربية. السادة الكرام، ضيوف الندوة الحاضرين سواء من داخل المملكة أو من مصر أو من دول الخليج أو من الدول العربية الأخرى، السلام عليكم ورحمة الله وبركاته. نرحب بكم في الندوة العلمية الافتراضية لمستجدات علاج قرح القدم السكرية والجروح المزمنة، وهي الأولى التي تعقد بهذه النسخة على مستوى العالم العربي. The first Pan-Arab Virtual Symposium on Diabetic Foot Ulcers and Chronic Wounds Management، والتي تقيمها مؤسسة ملتقى الخبرات لتنظيم المعارض والمؤتمرات كشركة معتمدة لدى الهيئة السعودية للمعارض والمؤتمرات ولدى وزارة التجارة بالتعاون مع شركة عناية الطبية. تقام هذه الندوة على مستوى العالم العربي، حيث يشارك فيها أساتذة متميزون ومتخصصون في هذا المجال من جمهورية مصر العربية، إلى جانب الأساتذة المتحدثين المحليين من المملكة العربية السعودية. تهدف الندوة لاستعراض آخر المستجدات في إدارة علاج التقرحات السكرية والمزمنة، وإلى الحفاظ على الأطراف من البتر، وهو هدف إنساني نبيل وعمل طبي عظيم أصبح الآن ممكنا في ظل المستجدات من وسائل التكنولوجيا الحديثة التي أصبحت متاحة الآن ومجربة. تتكون ندوتنا من جلستين علميتين و7 محاضرات وحلقة نقاش بعد كل جلسة. أنا الدكتور عبد الحفيظ يحيى خوجة، استشاري طب مجتمع وإعلام صحي، رئيس اللجنة المنظمة لهذه الندوة. أتشرف بتواجدي بينكم ومعكم خلال فقرات هذه الندوة العلمية لتقديم وإدارة الحوار مع الأساتذة المتحدثين الكرام، وأتمنى لكم قضاء وقت سعيد ومفيد بما سيقدمه أساتذتنا الأفاضل من مختلف التخصصات الطبية ذات العلاقة بالقدم السكرية ومضاعفاتها ومستجدات العلاج. For the non-Arab attendees, Mr. Chairman, Your Excellencies, distinguished speakers, dear attendees, ladies and gentlemen, Assalamu alaikum wa rahmatullahi wa barakatuh. We welcome you in the first Pan-Arab Virtual Symposium on Diabetic Foot Ulcers and Chronic Wounds Management, which is organized by the Forum of the Experiences for Organizing Exhibitions and Conferences, and with the support of Inaya Company. There will be 7 lectures and 2 sessions. Each one will be followed by a panel discussion setting. I am Dr. Abdel Hafiz Khoja, consultant of community medicine and health information. I'm honored to be with you to present and manage the dialogue with the distinguished speakers in this scientific symposium. I wish you a valuable and useful time with updates and challenges in the management of diabetic and chronic ulcers. السادة الحضور، وقبل أن نبدأ البرنامج العلمي أود أن أنوه إلى بعض النقاط المهمة في هذه الندوة. أولاً، الساعات العلمية المعتمدة من الهيئة السعودية للتخصصات الصحية لهذه الندوة سوف تضاف تلقائياً إلى حساباتكم في الهيئة اعتباراً من يوم 20 من شهر يناير الحالي بإذن الله تعالى. ثانياً، بالنسبة لشهادات إثبات الحضور للندوة نرجو الدخول إلى نرجو تسجيل أسمائكم باللغة الإنجليزية على الواتساب على الرقم الذي يظهر أمامكم الآن، وهو 055 056 5619، وسوف نكرره، ولكن نأمل أن تتمموا إدخال معلوماتكم باللغة الإنجليزية قبل انتهاء الندوة، وسوف يتم برمجتها وترسل إليكم الشهادات على الواتساب في خلال 3 أيام إن شاء الله. وقبل أن أنتقل للفقرة التالية أود أن أنوه بأننا تعودنا في ندواتنا التي نقدمها من خلال ملتقى الخبرات أن تكون هناك مسابقة وجوائز للمسجلين في الندوة نقدمها من وقت لآخر، وفي هذه الندوة ستكون هناك مسابقة وجوائز قيمة. فالفائز الأول سوف يحصل على جهاز أبل آيباد، والفائز الثاني والثالث سوف يحصل كل منهما على سماعة أبل إيربودز برو. سوف تبدأ المسابقة في نهاية الندوة وخلال جلسة المناقشة الأخيرة، وبعدها سيتم بالقرعة الإلكترونية اختيار 3 فائزين منكم يمنحون الجوائز التي ذكرناها. حظا سعيدا لكم جميعا. الآن أيها الإخوة الكرام، يبدأ البرنامج العلمي مع الجلسة الأولى والمحاضرة الأولى، وهي بعنوان الاعتلال العصبي الطرفي السكري، الخطورة المهملة للقدم السكري التقرحي. Diabetic peripheral neuropathy, the ignored risk for diabetic foot ulcer. ويسعدني ويشرفني أن أقدم المتحدث الأول في هذه الندوة، سعادة الدكتور أشرف عبد القيوم أمير. دكتور أشرف, he is a consultant family medicine, honorary assistant professor of medicine, القرى University مكة المكرمة. He is a physician executive MBA, University Tennessee, Knoxville, USA, and Executive Director of Executive Health Services and External Affairs, former Chief Medical Officer in the International Medical Center IMC in Jeddah. Dr. Ashraf Amir, he is the CEO of Salam Home Healthcare Company, Jeddah. And also, he is the Vice President of the Saudi Society of Family and Community Medicine. He is a member of the National Committee for Primary Healthcare Development, Saudi Health Council, and member of the Strategic Committee for the Council of Cooperative Health Insurance. Dr. Amir, he is a representative of the Saudi Society of Family and Community Medicine for the Global Family Doctor WONCA East Mediterranean region. Dr. Amir, welcome you, and you can share your presentation now. You will have 25 minutes, please. We'll start from now.
الحمد لله رب العالمين والصلاة والسلام على سيدنا محمد وعلى آله وصحبه أجمعين. السلام عليكم جميعا. Ladies and gentlemen, dear colleagues, it's a privilege for me to stay with you or to be with you today. And I would like to thank you, Dr. Abdul Hafid, for this wonderful introduction. Ladies and gentlemen, before I start, I would like just to say a statement just to pave the way and to set up the stage for my topic. In fact, my topic is a very important subject that is going to be highlighted here in 25 minutes, which will highlight the importance of the preventive measures that we have to have in order to save the foot of the patient with diabetes from amputations and to prevent the further deteriorations of the diabetic foot ulcer by ignoring very important status of interventions that might make the total change and might make the paradigm shift in the management of our patients. So as you know, diabetes is a global medical emergency, and the distribution of diabetes across the globe is very numerous. And our share in the Middle East and the North of Africa was very high in terms of the high prevalence of diabetes in the globe. Was allocated in the Middle East and the North Africa. And this is the International Diabetes Federations in 2019 stated that Saudi Arabia and Egypt, one of the topmost countries with a high prevalence of diabetes in the region. And of course, we have to admit the bad facts that 1 in 8 adults in the MENA regions is a patient with diabetes. And as we state today, in 2019, we have 55 million, but this number is going to be doubled in 2045. So 2045 is a very challenging year for all of us to manage our patient with diabetes and to prevent this kind of epidemicity that's going to sweep the whole regions with a lot of financial burden on our healthcare system. 45% of the people of patients with diabetes, unfortunately, they are hidden in the communities and they are not in a proper encounter with the healthcare system. So still we are lacking behind. And whatever we are managing now of patients with diabetes, this is just represent the tip of the iceberg. Still we have a lot of people in the community, they are in the pre-diabetic state and they are going to be our future clients for a full-blown picture of diabetes with its all complications. 10% of people with diabetes, they have foot ulcer, and this will highlight the big magnitude of the problem that we are encountering in our day-to-day practice. And the risk of the foot ulcer across the diabetic patient life, it varies from 19 to 34, maybe to 50% in some studies. So this is very quite prevalent problem that we encounter. 10 to 15% of diabetic foot ulcers, they don't heal. And this is the real challenging part of those people who don't have a healing ulcer. Ultimately, we exhaust all the resources and ultimately we have no choice but to go for amputations. 20% of the hospital admissions for patient with diabetes is usually because of diabetic foot ulcer and the neuropathic pains and the management of osteomyelitis seen in about 15% of patients with diabetes for ulcer. And this is very hard, in fact, clinical entity to manage because it needs a lot of interventions, a lot of antibiotics, and a lot of hospitalization. But the most important fact that I would like to reinforce here in all these facts is that the diabetic neuropathy alone causes about 45 to 60% of the diabetic foot ulcers. So that's why I have selected this topic, because this is very important for us to learn more about diabetic neuropathy. So ladies and gentlemen, in spite of the paradigm shift that has been highlighted in the past 1 decade by having more molecules for patients with diabetes as medications, oral medications, smart molecules of insulins, but in spite of all these revolutions in the management therapy, still there was no change in the patient A1C. So still we have more than 50% of our patients across the MENA regions, they are not diagnosed and they are not in a tight glycemic control. And we have learned from the landmark of diabetes studies, which is UKPDS, that 1% of reductions of the hemoglobin A1C will be represented by a remarkable reduction in the microvascular and macrovascular complications, And the most important thing which is related to this topic is 1% reductions of A1C will be associated with the reductions of 43% of amputation and a fatal peripheral blood vessel disease. So this is very important statements, and this will constitute the roadmap for us in order to have our patients tightly controlled for A1C in order to prevent this kind of devastating consequences. So we know that diabetic neuropathy is one of the most important leading cause for non-traumatic lower extremities amputations in the MENA regions. Of course, when we just want to identify what is the definitions of neuropathy, it's a lack of sensation, movement, or autonomic functions in certain particular place or particular area of the body. And as you can see, the name of the game here in neuropathy is hyperglycemia. Glucotoxicity is the one which initiates the whole process by which there will be a capillary pathology, decreased axon transport and axon atrophies, and the neuron will get necrosed and ultimately will lose its functions and decrease the conduction's velocity, and all the signs and symptoms of neuropathy, as we are going to learn, will be highlighted by the patient. But this is not the whole issue. But also hypoglycemia or hyperglycemia increase the nerve glucose fructose and increase the nerve sorbitol, which decrease the sodium potassium ATPase and ultimately decrease the conduction velocity, and ultimately the patient will be landed in the neuropathic pain sign and symptoms that we have to address. So this is the nerve. In fact, we have in the nerves, we have the large and the small nerves, and it has many functions. It has the motor functions, sensory functions, and autonomic nerve functions. But here, as we see, there is in the small nerves, it's considered to be important for the touch, for the cold and the warm sensations. But for the autonomic, it represents the heart rate and the blood pressure. That's why patients with diabetes, with the autonomic derangement of the nerve, they will have postural hypotensions and they have gastropathies. But also because of the autonomic nervous system impairment, they will have a loss of atrophy or a loss of the skin texture and atrophy and absence of the hair. So this is in fact, this is a very surprising and very astonishing that 65% of our patients with diabetes in the Kingdom of Saudi Arabia, they have diabetic peripheral neuropathy. And this has been stated by Halawa in the national survey in the kingdom. This was in 2010. So what are the challenges of neuropathic pain? Usually it is underreported, mistreated, undertreated, misdiagnosed, underdiagnosed, and it's always associated with a lot of disability because the patient has a loss of sensation and he has a lot of extremely excruciations, pain, and so forth. So that's why he have this kind of association with disability, and usually it is poorly treated. The prevalence, when we just compare the MENA regions with the Western regions, we find there is a big discrepancy in terms of the prevalence of diabetic peripheral neuropathy. In Saudi Arabia, in the Middle East, in fact, by Halawa, it was about 65%. In Mahrous, it was 36%. So it was very highly prevalent in the MENA region. But look here, in the Western region, the painful diabetic peripheral neuropathy is just only 15%. And there is, in fact, a lot of contributing factor beyond the scope of this presentation. So we have to learn that the peripheral neuropathy types, we have a sensory neuropathies where we have a positive symptom. So most of the patients, they have burning sensation, tingling sensation, electrical shock, pins and needles, and all this is because of the hyperexcitability of the neurons. But once the problem established for a longer period of time, the exhaustion of the neuron system and the necrosis of the nerve endings will result in complete atrophy, and this will be highlighted by the negative symptoms in terms of numbness and ultimately loss of sensation. But in the same time, with the peripheral neuropathy, there is a motor neuropathy. So the motor neuropathy, as we can see in this picture, the intrinsic muscles of the foot resulting in clawing and toes change in the architecture, which is one of the most important features of patients with a motor neuropathy and with diabetes. How about the autonomic neuropathies? Of course, because there will be a dry skin and there will be hair loss and the brittle nails, which is very common in patients with diabetes. So why it is very important to detect diabetic peripheral neuropathy in the early stage? Why? Because there is a compelling evidence that many trials across the globe stated that reductions on if we detect diabetic peripheral neuropathy in early stage, there will be a reductions in the prevalence of ulceration by almost 80%. So this is very surprising, and this is very encouraging for us to work on that directions. And the painful symptoms are common, severe, and often leading to depression. So we find those patients with a peripheral neuropathy, painful diabetic peripheral neuropathy or ulcers or neuropathic pain, usually they have depressions and anxiety, and they have sleep disturbance, and even the quality of life has been totally impaired. So what are the risk factors for diabetic neuropathy? Of course, there is many factors, but I could summarize it in terms of the duration. Those patients who have a longer duration of diabetes, they are more likely to have diabetic peripheral neuropathy. Elderly patients, patients with the cardiovascular and renal disease, patients with the poor glycemic control, especially when the A1C goes more than 10% or 12%, high body mass index. So that's why weight reduction is very important. Other habits like smoking and presence of retinopathies and other complications of diabetes aggravate the complication of diabetic neuropathy, vitamin B12 deficiency, and alcoholism. And this is one of the very important trials that showed it's not only the duration of diabetes or the uncontrol of diabetes, which is always associated with diabetic neuropathy, but also there is another confounders, which is very important factors like hypertension, smoking, body mass index, hypertriglyceridemia. So this is the cocktail, and this is the usual presentation for our patient in this part of the world, in Egypt and in Saudi Arabia, in the Gulf area, and even in the Arab world. So we don't have patient who comes to us with a patient with diabetes, but also usually they comes in a metabolic syndrome fashion, like hypertension, dyslipidemia, diabetes, obesity, and smoking. And this is the clinical manifestation of diabetic peripheral neuropathy. Usually it's bilateral and symmetrical. So usually it happens in both extremities, in the lower extremities, and the signs and symptoms usually progress from the distal to the proximal part, and usually it goes as high as the knee and maybe a little bit more. So as we said that we have, when we would like to elicit the symptoms of diabetic peripheral neuropathy, usually there is a positive symptoms because of the hyperexcitations of the neuron in the early stage of neuropathy. And the most important cardinal feature is allodynia. Allodynia is the perception of painful stimulus by a stimulus which does not usually provoke pain. So like the air, when somebody just touch the skin, there will be an extensive pain perceived by the patient. And this is exaggerations of the neurons, which cause allodynia. Hyperalgesia and paresthesia, this is one of the positive. But how about the negative symptoms? When the duration of diabetes and diabetic peripheral neuropathy exceeded many years, usually there will be a decline in the functions of the neurons, and there will be ultimately there will be anesthesia, hypalgesia, and hyposthesia. So this is classically how the patient comes to our clinic presenting with diabetic neuropathy. He has burning sensation, tingling sensation, shooting, electrical shock, numbness. But what is the commonest presentation? This has been highlighted by Halawa survey nationally in 2010, when 68% of most of our patients, they come with a burning sensation, harara. He feel a burning sensation. And then this will be followed by the second presentation, which is numbness, and ultimately tingling or pricking. This is only 60%. So as we know, the functions is usually impaired by the diabetic neuropathy, and it usually touch the most important part of the day-to-day activities like the sleep, enjoyment, recreation, social activities, mobility. That's why diabetic neuropathy is usually associated with a poor quality of life. And we have to consider this because once we treat the patient, we have to treat the patient in total. We don't have to focus to treat the diabetic neuropathy, but we have to look into the other comorbidities and the impact of this problem on the patient's life at home, at work. So definitely we'll find that this is a patient is a candidate for depression or a major anxiety disorder where we have to treat it by antidepressant medications. So diabetic neuropathy usually progress over time. So it has a period where there is a subclinical, where we have 50% of our patients, they are patients with diabetic peripheral neuropathy, but they don't have any symptoms at all. But once the condition progresses for many years to go ahead, there will be a nerve conduction abnormalities, and then the patient will start having the symptoms of tingling and burning sensation, numbness, and so forth. And this will be followed by decrease in the vibration sensation, and vibration sensation is the first sensation that is usually lost in the patient with diabetic neuropathy, and then decrease the pressure sensation by the monofilament, and then decrease the reflexes, and usually the patient have symptoms of numbness and pricking. So this is usually a progressive, the way that diabetes is a progressive disease, diabetic peripheral neuropathy is also a progressive disease. But clinically, from the practical point of view, how to diagnose and how to screen our patient for diabetic peripheral neuropathy, usually here in this part of the world, we use a DN4 questionnaire, where there is almost 7 questions, very, very simple question. The first question, does the pain have one of the following characters: burning, painful, electrical shock? And this is yes or no. So this is 1.1 point. And then the other question, is the pain associated with one of the more following symptoms like tingling, pins and needles, numbness, and itching? And this is yes or no. And then we do some kind of clinical examination by using the 10-gram monofilament test and 10 different points in the sole of the feet to identify the hyposthesia to touch. So if it's yes, we put 1 point, and hyposthesia to pricking by pricking the patient with a pin. So this is the second way to go. And then the fourth one, the painful area, can the pain usually be increased by brushing? So the brushing is a static allodynias, and by this, with all the 7 questions and the 3 clinical examination, if the patient score more than 4 points, so this is a diabetic peripheral neuropathy, and usually the sensitivity is almost 89%, and the specificity is more than 90%, and usually this is a very important tool to diagnose patients with the diabetic peripheral neuropathy. So how to manage the patient with diabetic peripheral neuropathy? Usually the diagnosis, once we establish the diagnosis by using the DN4, we have to treat the underlying cause. Diabetes has to be treated as a first important priority. So we have to bring the A1C to 6.5 to 7% as much as we can. And then we have to treat the other comorbidities like hypertriglycemia, dyslipidemia, and hypertension, obesity, smoking cessations. And then we start the medications that we can give the patients. And usually our intention is to reduce the pain by 30% to 50%. And this is usually considered to be a successful way of management. And our intention is to improve the physical functions, improve the psychological status, and improve the sleep and the quality of life of patients. So these are the guidelines, which were the international guidelines for the management of diabetes, diabetic neuropathy. And I was privileged to be one of the authors in the Middle East region in 2010 and 2017. So the first line management is a pregabalin, gabapentin, and duloxetine across all the international guidelines. So this is the first line management, which is pregabalin, gabapentin, tricyclic antidepressant, and duloxetine. And then the second line management, like other medication, which is not very commonly used. So, ladies and gentlemen, dear colleagues, I just want to summarize all what I have said in a very simple statement, but it's a home take statement. So first of all, we have to screen and identify diabetes peripheral neuropathy by using the DN4. And we have to admit that diabetic peripheral neuropathy is a very common and very prevalent complication of diabetes in our region. So we have to allocate all the resources, and we have to manage our setup in our clinic and in our healthcare system in order to capture those patients early stage, in order to prevent or delay at least the complications of the devastating consequences and the prognosis of diabetic neuropathy into diabetic foot ulcer. So all patients with diabetes should have a foot examination performed annually. This is the recommendation, but also you have to customize based on the patient profile. So some of the patient every 6 months, some of the patient every 3 months, but clinically speaking, in order to protect the patients and in order to give the best, the state-of-art treatment to patient, please try to examine the protective sensation for in the feet of your patient every time he comes to you, whether every month or 2 months or even 3 months. Then treat the underlying causes like diabetes and treat the associated comorbidities like the other comorbidities like hypertension and others, and treat diabetic neuropathic pain by the first line management, which is pregabalin, gabapentin, tricyclic antidepressant, and duloxetine. And then identify the red flag. If the patient does not respond and there is a signs that the patient is getting into diabetic foot ulcer, definitely you have to refer the patient to the surgeon, to the pediatrist, or to the neurologist. And then never forget that our patient is an important partner with us. He's not anymore a passive individual in the management, but he's the most important individual that he has to share with us his concern and to work with us for the best interest of the management plan to be taken. With this, ladies and gentlemen, dear colleagues, I would like to thank you for your active listening, and thank you very much, Mr. Chairman, for giving me this wonderful opportunity. Thank you.
Thank you very much, Dr. Ashraf Amir, for this excellent presentation about diabetic peripheral neuropathy. And another thanks for you about the time. You consumed only 21 minutes from the 25. So maybe you will grant it to other speakers if he has a lot of knowledge to give it. Thank you very much.
Thank you.
إخوة الحضور، وقبل أن ننتقل إلى المحاضرة التالية أود أن أكرر بأن الحصول على شهادة الحضور في هذه الندوة يلزمكم الدخول إلى الواتساب على الرقم المنشور أمامكم 055 056 5619 وتسجلوا أسماءكم باللغة الإنجليزية كما تشاءوا أن يظهر الاسم على الشهادة، والشهادة سوف تصلكم في خلال 3 أيام. الملاحظة الأخرى إخوتي الكرام، هذه الندوة، هذا الويبينار يبث متزامنا مع ما يحدث الآن ومباشرة على حساب مؤسسة ملتقى الخبرات على تويتر، ويظهر أمامكم هذا العنوان FEXC2020. البث مستمر ومتزامن الآن على تويتر. النقطة الأخيرة، لا ننسى أن نبشركم بأن هنالك مسابقة علمية سوف نعقدها إن شاء الله في نهاية هذه الندوة، ولها جوائز قيمة، وألف مبروك مقدما لمن سيفوز بهذه المسابقة. الآن ننتقل إلى المحاضرة الثانية في الجلسة العلمية الأولى، وهي بعنوان الطب الإلكتروني الحيوي لإنقاذ الأطراف Bioelectronic Medicine Securing Limb Salvage. ويشرفني ويسعدني أن أقدم المتحدث سعادة الدكتور أحمد السواح. دكتور أحمد السواح is the Vice President of Alia Group Company and the CEO of the Third Eye Company. He is renowned expert in the local and international pharmaceutical arena with almost 40 years experience. Dr. Sawah has a unique exposure to various pharmacy disciplines, including licensing and the transfer of technology in alignment with major multinational pharmaceutical companies. He was instrumental in establishing the pharmaceutical industry in the Gulf area. He participated as well in establishing the first multi-purpose facility in the MENA region to produce advanced active pharmaceutical ingredients located in Riyadh in Saudi Arabia. During his career life, Dr. Al-Sawah, he was involved in the beginning of recombinant DNA genetically engineered drugs, as well as the subsequent biosimilar guidelines and implementation. Dr. Ahmed Al-Sawah, you can start sharing your presentation now, and you will have 25 minutes starting from now.
Okay, thank you very much, Professor Dr. Khoja. And I think what we are going to present today, I consider it as second to none new technology for the 5 years to come in order to improve the quality of life of poor patients who have diabetic foot ulcer and try to salvage amputation and save limbs.
الصوت يا دكتور.
نعم.
الصوت راح. هي تفضل.
ده أعلى صوت عندي.
الفيديو ده له صوت ولا بدون صوت؟
بدون صوت؟
ايوه الفيديو الان بدون صوت.
انا رافع الصوت على اخره، ما ادري يعني.
لا غير مسموع.
غير مسموع. طيب نوقفه الان ونتكلم على المحاضره. انا هعرج على محتوياته.
نعم. ممكن يستمر وحضرتك تشرح عليه.
خلينا بس الاول نبدا من الاول هنا.
ايوه نرجع الفيديو من الاول وحضرتك اشرح عليه وهو بيعرض.
طيب خلينا بس نبدا الاول هنا. نتكلم على شويه باك جراوند مهم جدا في الكرنت ستاتس اوف wound management. Actually I'm going to use William Ennis publication which actually correlate a lot of factors affecting healing process, and I invite everybody to look at this paper because it's very much valuable one, which actually led me to try to meet him in person in Jacksonville, Florida later on after I went through this last January. So the wound care industry has generated an enormous amount of products, dressings, devices, and more recently, scaffoldings and cell-based therapies. But to date, only 50 to 70% of wound heal within randomized controlled clinical trials. So we have a big problem, not only for the diabetic foot ulcer healing, as was referred by Dr. Ashraf, but this is generally speaking for wounds. The chronic wounds has a major limiting factor of the inflammatory state. So the more persistent inflammatory state, the more of unhealed wounds. The more we can deal with the persistence of the inflammatory state, the more that we can heal the wounds. And again, this is a precious paper I was referring to. Dr. Ennis William is a professor of vascular surgery in Chicago, Illinois University. He is also the president of the American College of wound care and tissue repair. Also, he is the co-founder of what's called Healogics. Healogics is the biggest ever vascular surgery treatment. They actually receive 330,000 patients a year. So I invite everybody to go for this publication, which you can provide later on. If we look at the WHO organization statements about the total bacterial resistance on humanity as an introduction to the coming technology and how it impacts us. So they mentioned that antibiotic resistance is a major global health threat, causing 700,000 deaths a year. This will reach 10 million by 2050, overtaking cancer as a cause of death. Okay, this will put us in a dilemma when we look at the future, the dark future of antibiotics, or the post-antibiotic future, actually with the common bacterial infection, minor energies could actually lead to death. So a new publication actually in 2020 suggested that several nanoparticles is a solution for antimicrobial resistance, and also researchers have used liquid metals. So here they compare between the liquid metals and the antibiotics with all its generation, including the latest new generations of antibiotics. And they came up of a conclusion that the technology uses nano-sized particle of magnetic liquid metals, including nanosilver, will kill bacteria and bacterial biofilm. The method used precision engineered liquid metal to physically shred bacteria and to shred this and smash through the biofilm. The new study, the team tested the effectiveness of the technology, two types of bacteria biofilm, gram-negative and gram-positive, and after 90 minutes of exposure, the liquid metal nanoparticles actually destroyed the bacteria. 99% of the bacteria was died. Importantly, that the bacteria destroying droplets did not affect the human cells. So this will lead us to the new branch of medicine, which is called the bioelectronic medicine, focuses on energy of healing. So energy should replace in the future the chemical molecules which actually use right now. And this is the beginning of the new era of tetrasilver technology, which is a part of this bioelectronic resonating energy. Still the video is not here?
الصوت ما في صوت يا فندم.
نعم.
ما في صوت في الفيديو، لكن حضرتك
واضح عندك من الصوت يا دكتور؟
نعم.
الصوت في الفيديو ما في.
And I will explain the video. This is the tetrahedral structure of the Ag4O4, a molecule which has never seen before. It's a tetrahedral structure called tetrasilver tetroxide. It's 4 atoms silver, 4 atoms oxygen in a non-ionic form. So it doesn't work by touch. It works with the great electromagnetic energy. So it's a spray and gel. The magnetic energy produced by this technology actually kill the bacteria without the need of touching them by the high speed of the 910 terahertz electromagnetic resonating energy in a speed of light. As you can see, now the bacterial cell would be shredded, even if the biofilm itself, it is penetrated. It eradicates the most resistant bacteria like MRSA and vancomycin, also resistant bacteria. One very important rule that this technology stimulates the stem cells from the neighboring lipid tissues, attract them to the site of inflammation, immediately reduce the inflammation, release cytokines and growth factors, and accelerate the healing process in a regenerative way of treatment. It's not degenerative, because you will see the cases and you'll see how tissue is regenerated through this technology. It also affects the pain, reduce the pain dramatically by making a space between the nerve cells and the site of the inflammation. I need to further highlight the technology, because it's very important to know what's going to happen. I will do it again here. Yep. Here is the photograph using the electronic microscope to show the 4 silver atoms and to show the dense area inside of high electromagnetic resonating energy, which has been measured to be 900 terahertz. This is the core of the technology. It will shred the bacterial biofilm in very, very speedy time. It will stimulate the stem cells to regenerate the tissues. It will reduce the pain, and this is the magic of this technology. So as I mentioned now, these are the 3 elements which we will see when you use this technology. It has immense bacterial killing power, rapid tissue regeneration through stem cell stimulation and migration to the site of inflammation, and pain reduction. For the bacterial killing mechanism, tetrasilver technology gel and spray in low concentration has superior pathogenic killing effect in a very low strength due to the emitting of electromagnetic resonating energy, as I mentioned before, and it kills the most resistant bacteria biofilms and act as a killing machine without the need that the silver atoms inside this non-ionic structure touch the microbe. It also actually attract the stem cells, and as we all know, there are limitations of getting the stem cells available nowadays, especially that these include large numbers of cells required for an effect, complex preparation, complex delivery methods, and poor cell retention in targeted tissues. To treat the DFU wounds, you don't need to go into all this complicated process. There's a proverb, British proverb says, there is 100 ways to skin a potato. If we have a very simple technology which could attract the stem cells without all these costs in a practical way and simple application, then this can do the role. That's why what's happening here, that the tetrasilver stimulates mesenchymal stem cells to migrate to the trauma site. Mesenchymal stem cells can sense the degree of inflammation and respond by releasing growth factors and cytokines and reduce inflammatory process and form replacement tissue. This is a regenerative kind of therapy. It's not degenerative like the classic wound. Tetrasilver technology shortens the inflammatory stage of wounds, which speed healing times and reduce scarring. So nanosilver demonstrated approximately 5-fold acceleration healing process and regeneration capabilities of stem cells compared to the unaided healing of the body. It also reduces the pain, as I mentioned before. It's effective reducing the pain through its high electrical conductivity and the chemical inertness of the metal. Pain is reduced by manipulating the electrical pulse of the sensory nerve ending. So before we go into the cases which reflect the superiority of this kind of technology. I want, because some people who are seeing this technology for the first time, when they see the cases, they might say it's too good to be true. So I promise you that all the details of doctors and contacts of the doctors who actually tried this and applied this for the last 2 years are available upon request. So we will start with the diabetic foot ulcer, and you can see this case is extremely difficult, and I'm quite sure that all the participants, all the vascular surgeons will look at this as ready for amputation, but it is not. This is a diabetic patient with severely infected diabetic foot ulcer planned for amputation. But look here, after 35 days, we see the revascularization, granulation tissue is coming up after 56 days, and finally after 3 months. This is how to make a person who could be handicapped after amputation to a working person, to his society and his family. So full wound healing after 90 days of treatment with tetrasulfate tetroxide. We prevented amputation. We have never used the fact for this case or even graft. This is another case of one of our speakers of today, Dr. Mustafa Sliman. Sorry for that, I took it from him. And this is a 45-year-old diabetic patient with diabetic also ulcer. I'm quite sure he will explain further, but you can see here how it was ended in 12 weeks to a happy end. This case being done in Saudi Arabia, I put this especially to show the impact of the stem cell stimulation and the regenerative way of healing the wound after 30 days. We have the patient's, his name is Abu Ibrahim from Riyadh. This is another case also, which I'm quite sure will be explained thoroughly with Dr. Mustafa, so I don't want to repeat it here for the sake of time. This is very important case because as we could hear from doctors that ulcer in the heel means below or above knee amputation. And you will see this case treated with the tetrasulfate technology, spray and gel, after 7 days, after 30 days, and after 2 months. Now, it is strong enough that he can walk on it without any kind of complications. This is what I was able to get from his treating doctor. This case, again, you might say too good to be true, but again, I have the reference here, but unfortunately, I don't have the in-between photos. So I have the first one, and I have the last one after 45 days. This is really miraculous. Another difficult case, 48 years old diabetic patients, and as you can see, all the cases I'm presenting were prepared for amputation. 40 years old diabetic patient with diabetic foot ulcer planned for amputation, and you can see now after 13 weeks how it looked like. No scar. Another diabetic foot ulcer, also with great success in 75 days without amputation. This is gangrenic diabetic foot for 50 years old female, and in 70 days it has been treated. This case, I have participated myself with Dr. Rafat Naga in looking at it. It's a kind of calf muscles gangrene, and it was subject to debridement, full debridement, and without any antibiotics, without any graft, it has been healed completely in 2 months time. So when I say no graft, this is look like amazing. Another case of infection in the breast. This was a female which went to reduce the size of the breast, and she had distribution of the vertical wound after 1 week. And after only 3 weeks, we saved the breast here. Now we are talking about venous ulcers, and as you can see here, this difficult case again, it was actually unhealed for 2 years. And after 2 months,
Dr.
it was
Ahmed
completely
Al-Sawah.
healed.
Dr.
أيوة.
Ahmed Al-Sawah, you almost coming to the end of your lecture.
I'm about to finish. I'm about to finish.
Thank you.
But let me go further for 1 or 2 minutes more, if you can allow me.
Okay, sure. Okay.
This case is the latest case we received only yesterday from Aswan, the south of Egypt. And this was a non-healing arterial ulcer. And only 35 days, it has reached this state of regenerative healing with a very nice rosy pink skin. And look for the bed sores. This case of bed sores took only 74 days to reach also a very nice skin. And that's it. Thank you very much. I finished.
شكرا لكم سعادة الدكتور أحمد السواح. وننتقل إلى المحاضرة الثالثة. وقبل ذلك أيضا أود أن أنوه إلى الإخوة الحضور الكرام الذين لا زالوا يتساءلون كيف نحصل على شهادة الحضور. أولا شهادة الحضور كما ذكرنا موجود الرقم على الشات، بإمكانكم أخذ الرقم وهو 055 056 5619. هذا الرقم أدخل عليه وسجل اسمك باللغة الإنجليزية كما تشاء أن يظهر اسمك على الشهادة. الشهادة ستصلكم في خلال 3 أيام إن شاء الله. بالنسبة للساعات العلمية سوف تضاف إلى حساباتكم في الهيئة السعودية للتخصصات الصحية اعتباراً من يوم 20 من شهر يناير الحالي. أيضاً أود أن أنوه للإخوة الحضور بأن هذه الندوة تبث مباشرة الآن على حساب مؤسسة ملتقى الخبرات على تويتر على العنوان الظاهر أمامكم الآن @FEXC2020. الآن مع المحاضرة الثالثة في الجلسة العلمية الأولى، وهي بعنوان دواعي البتر والإنقاذ للقدم السكرية. Indications for salvage and amputation for the diabetic foot. المتحدث في هذه المحاضرة سعادة الدكتور خالد محمد عبد القادر إدريس. Dr. Idris, he obtained his Doctor of Pediatric Medicine degree from Bari University, Miami, Florida in 1979. And then he was certified by the American Board of Medical Specialties in Podiatry in prevention and treatment of diabetic foot wounds in 2001 and podiatry surgery in 2002. Dr. Idris came back to the Kingdom of Saudi Arabia to work at a number of government and private hospitals. And by the year 2006, he opened the first specialized podiatric foot and ankle practice in the country, which was later converted to a multi-specialty clinic. He is a member of the National Committee on Diabetes Mellitus and Health Education Program of Governorate of Makkah Al Mukarramah. Dr. Idris is a consultant of MOH, Ministry of Health, Diabetes Center in the Kingdom. He also represents the International Working Group on the Diabetic Food in Holland. Dr. Idris is an associate of American College of Foot and Ankle Orthopedics and Medicine. He is a frequent lecturer and trainer in number of local and international symposium. Dr. Khalid Idris, حياك الله. You can start your presentation and you will have 25 minutes starting from now.
طيب بسم الله الرحمن الرحيم. I would like to discuss first what is the definition of the diabetic foot. If we look at the definition of the diabetic foot in many books and even by the World Health Organization, we will see that it's a very huge and cumbersome definition. I've been proposing for the last 15 years or more even that the definition of the diabetic foot should be the foot of every patient diagnosed with diabetes on the day of diagnosis of diabetes. Because if we do that, we are going to save that foot from amputation by early intervention, by annual examination, by education to the patient. So what is the primary prevention? Why is primary prevention? I know my presentation is supposed to be about amputation. I'm going to get to that now. But we have to talk about prevention because by the time we reach amputation, we have all failed. And no technology in the world will save from complete amputation. 85% of diabetic foot amputations are preceded with a small ulcer, with an ulcer. So how can we prevent ulcers? Simple podiatric care can prevent ulcers. What is podiatric care? Simple debridement of keratosis, simple cutting of nails, simple education to the patient. So we need to do that when the patient is first diagnosed with diabetes so they don't become a statistic. So what is salvage? We all talk about salvage. Interestingly, many people think of salvage. We hear it all over the social media that la lil amputation, no to amputation. That's just simply nonsense. There will be amputations because the patients at some point, it's unfortunate that there will be amputations because unfortunately the patients come so late or there is a delay in diagnosis, there is poor judgment on of treatments. So there will be some loss of tissue. Salvage of the lower extremity is defined as keeping any part of the foot, to make it simple. So up to a toe part amputation, which is going to see, this picture is an actual patient of mine. This is the toe part amputation. This is salvage. The difference between salvage and a below knee or an above knee amputation, which is a major amputation, is that the patient can walk on their own heel. We can put them in a shoe, custom made shoe, yes, but not in a prosthetic, which has its own problems, as we're going to see now. What are the levels of amputations? You have forefoot, midfoot, rear foot, and I'm going to talk about a new kind of amputation that's called the heel amputation, which I do a lot of to save some of these, to save the patients from major limb amputations. 60% of patients with hallux or first ray amputation had a second amputation at a greater level within 6 to 10 months. So does that mean that amputating the hallux is a bad thing? No, it's a good thing. But what's happening here is that there's no follow-up with that patient, because once you remove the hallux or you move any one of the digits, you have transferred the load from that one area to another area. And if you don't put the patient in special shoes, you will have more amputations. Here are the levels of amputations. Transmetatarsal, Lisfranc's is at the end of the metatarsals. Toe part amputation is where you keep only the calcaneus and the talus. The secret or the important bone in the foot and ankle is the talus. If we lose the talus, then we have lost the foot. We are going for a below knee amputation. If I tell the patients many times, if I can maintain your heel, the heel bone, the calcaneus, you will walk. And at home, they walk without shoes, without anything. So transmetatarsal amputation, we divide that into distal and proximal. Mid rear foot amputation, Liz Frank's Chopard. Symes amputation is amputation at the level of the ankle. Very few people do that now. The last Symes amputation I did must have been 10 years ago, because no matter what you do, it's in the middle. It's between putting the patient in a shoe and putting the patient in a prosthetic. If you put the patient in a shoe, the shoes will swivel because there's only a small piece of the leg. So it doesn't really work, but it generally heals well. No more Symes amputation unless it's absolutely necessary. Mortality within 30 days of a hospital, mortality within 30 days of a hospital discharge was 10% or almost 10% in patients with a major amputation. Within 30 days, they die. 10% of them die. And the numbers vary from one study to the other, but the average is the 5-year survival rate of a major amputation is 50%. So 50% of the patients that undergo a major amputation die within 5 years. So this is the justification why we should do anything as much as we can, scientifically and humanely can, to save the foot of the patient, or better to say, to save part of the foot of that patient. A major amputation, this study calls it ominous. Ominous means it's something bad, something really bad can happen. And the studies go 22 to 76% of survival. So why not a Symes amputation? Because that little piece of leg does nothing. You need to do a below knee amputation so that you can fit the leg in a prosthetic. If the patient is bedridden, we're going for an above knee amputation, because that little stump will reulcerate. A lot of times will reulcerate. And why would they need that small piece of leg that will only give them trouble if they're bedridden? So we're talking above knee amputation. It's not easy. And we're going to talk about psychological effects later on if I have time. So what are the predictive values of limb loss? And this is where it's been said before, and I'm gonna say it again: teamwork. A podiatric surgeon alone doesn't work. An endocrinologist alone doesn't work. A vascular surgeon alone doesn't work. An infectious disease doctor doesn't work. An orthopedic surgeon alone doesn't work. We have to be a team. And I put these numbers here so that my endocrinologist and my family physicians who are part of the teams with us can look at these numbers and help me avoid it. Well, we can't avoid age. So if the patient is above 60, that's more of a predictor of limb loss. Now remember, we're not talking about partial amputations. We're talking about major amputations. If the ankle brachial index is less than 8, if you have gangrene, monomicrobial infection, usually we know that diabetic foot ulcers have polymicrobial infections. Studies show that if it's a monomicrobe, that microbe is going to get very strong, and it's more of a predictor for limb loss. White blood cells more than 15,000, ESR more than 100, CRP more than 15, hemoglobin under 10, and of course creatinine, high creatinine. But when I look at these numbers, almost all my patients have these numbers and higher. That's why we need to work in a team to bring these numbers down. I work from a surgical point of view, and the internist or the endocrinologist, the family physician work on the other side. So why do we amputate if amputation is so bad? Sometimes we have to amputate to save the life of the patient. Yes, they will have a chance, la samhallah, of dying within 5 years, but we would have saved their life because it would become a life-threatening situation. So primary amputation is only necessary for the unsalvaged diabetic foot. What is unsalvaged? Means we cannot keep the heel. This is what is unsalvageable. You cannot maintain the heel, and the patient walks on the heel. 50% of diabetic foot infections who have foot amputation die within 5 years. We already said that. So let's talk now about the indications. There are indirect indications for amputations. Ischemia is not an indication for amputation. You can have a patient with ischemia, but their feet are just fine. We have to protect them. Infection Soft tissue and and bone infection, osteomyelitis, is also not a direct indication for amputation. Of course, within degrees. If you have septic shock, or if you have necrotizing fasciitis, that does become an indication for amputation. But on themselves, ischemia and infection are not indications for amputation. What are the direct indications for amputation? If you have gangrene, nothing in the world will bring gangrene back. Nothing. If it's gangrene, it's dead. لا يعيدها إلا خالقها. God is the only one that can bring it back. It's dead. We're going to lose it. It's going to go. The question here becomes is how much are we going to lose? This picture, this hallux, nothing can bring it back to the world. It's dead. We're going to remove it. But if I remove it without doing an angioplasty, without the other team member doing their job, then we would probably, then we will lose the whole leg. So the picture on the left, that's before angioplasty. The picture on the right, that's after revascularization. See how beautiful the demarcation occurred. And then we can go ahead and remove that hallux. And this patient will walk with diabetic shoes, with custom-made shoes and custom-made insoles. And guess what? Yes, this is salvage. That's why I don't like it when people say no to amputation. It is no to the majority of amputations. We can decrease them. Of course, deep infection, necrotizing fasciitis, I just said it. Tumors. If a chronic wounds turn into squamous cell carcinomas, then you have to amputate. And believe it or not, pain is one of the indications of amputation, because and I've had few cases where I know I can save the limb, but the patient is in so much pain, neuropathy did not kick in so strongly, and this happens to be one of the 40% of the patients that Dr. Ashraf Amir spoke about that do not have neuropathy, and they have severe pain. So indications and level of amputation. How about the hallux amputation or lesser digits amputation? If you have wet gangrene, osteomyelitis, septic arthritis, or gross infection of the forefoot, we're gonna lose that forefoot. Of course, that is not done immediately. There's a lot of clinical workup that has to be done. We don't just go to the OR immediately. We first get together with the team. We discuss the vascularity. We do x-rays, we do labs, we do MRIs to decide which tissues we are going to lose. Because the worst thing can happen is if the patient has good vascularity and you heal the wound on osteomyelitis, on infected bone, or on a necrotic tendon that's on the inside, it's going to come back and bite you in the long run. So criteria to get away with it means the criteria to take in consideration to succeed with this level of amputation. If you don't have any palpable pulses, a 4-foot level amputation is not going to succeed. So you need at least one palpable pulse and an ankle brachial index of more than 2. And outcomes and prognosis is about 70% successful. How about the transmetatarsal amputation? Same thing, bone infection, tissue loss. You also need to have at least one palpable pulse for a transmetatarsal amputation. Or if there are no palpable pulses, we go to the vascular surgeon, they revascularize or they do their angioplasty, and then I have a palpable pulse. Then I do my transmetatarsal amputation. Then my success rate becomes very high. Transmetatarsal amputations have a very high failure rate. It's not long-term failure, it's short-term failure. They tend to open a lot. So it will open, you'll have a hard time with it, but in the end, they will heal, especially if the vascularity is good. And please, to my fellow surgeons, do not do the guillotine cut, boom, down like that, and then you have all the bones sticking out. Always with transmetatarsal amputations and most amputations, we need to remove more bone and leave some skin envelope to close after it, to close on top of the bone, and don't leave bones exposed sticking out of the wound. Midfoot, Lisfranc's, Chopart, the indication for that is the criteria is not well established. I think once you get to this level of attempting a foot salvage, I'd like to have my percentage to be at about 50% possibility that is agreed upon by myself, the vascular surgeon. Sometimes we get together and we discuss it. what are the possibilities that we can give this patient as the last level of salvage procedure. As long as the patient understands that there's a high possibility of going to a below-knee or an above-knee amputation, the infection is not too bad, the tissues are clean, and the calcaneus and talus have no infection, the fat pad is good, we can try for a chop-part amputation. This is what I call, what is being called now in the literature, a heel amputation. A lot of the centers, once they have infection in the calcaneus, they call it off and we go for a below-knee amputation. The fact is, we can remove up to 70% of the calcaneus and the patient will walk just fine. We have many patients with loss of the posterior leg muscles as well as the Achilles tendon, big part of the calcaneus. We make a special filling in the shoe and they will walk, and this is considered salvage. We have many patients of this kind. Osteomyelitis and necrosis. So is this a salvage procedure? Absolutely, yes, this is salvage. But we lost half the foot. Yes, so the patient can still walk with shoes, and in his house or her house, they can walk with nothing. They can be self-sufficient and independent. Pain. I will never forget this patient. He was of a Yemeni origin, and the only reason I say that is because of his accent that I cannot, and his words. He used to tell me, "Ana f'ardak ya Khalid," because of the pain. Now, we know that we can lose most of these tendons in this picture with vac therapy, with antimicrobial therapy, with debridement. This patient has had really good vascularity, ended up with a below-knee amputation. He was begging for a below-knee amputation. That's why I call pain as an indication for amputations. So once you see a picture like this, and I know in the previous presentation, we saw many pictures like this, antimicrobials alone will not heal such an infection. By the way, this patient is walking today. It's a teamwork. Antimicrobials, whether it's topicals, whether it's injectables, whether it's IVs, whether it's local, is only part of what we do as a team to save the foot of a diabetic patient. Thank you very much for your attention. That's the end of my presentation.
شكرا لكم سعادة الدكتور خالد إدريس على هذه المحاضرة القيمة، وخاصة ومما شدني بأن توجهكم كان منصب على الزملاء الجراحين والخبرة هذه التي أعطيتموها لمن يحضر معنا في هذه الندوة العلمية للاستفادة من خبرتكم وخبرة المتحدثين الأفاضل الموجودين معنا في هذه الندوة الافتراضية العلمية عن القدم السكرية. الآن لو بس تلغي الشير سكرين دكتور خالد لو تكرمت.
شير سكرين هو كأنه طيب اتلغى ولا لسه؟
Yes, being closed. Being closed, doctor.
Closed. Okay.
اتقفل؟
Yes.
لأنه أنا عندي لا زال موجود، الله أعلم ما أدري. طيب على العموم الآن حنبدأ في الجلسة الأولى للمناقشة والتي تخص الجلسة العلمية الأولى في هذه الندوة. معنا طبعا جمهورنا الأفاضل، سعادة الدكتور أشرف أمير، سعادة الدكتور أحمد السواح، سعادة الدكتور خالد إدريس. الآن الأسئلة التي وصلتنا في الحقيقة كثيرة ولكنها متشابهة، وقد تعودت في أن ألتقط المتشابه منها ولو قدم في صيغ مختلفة وجمل مختلفة ولكن المعنى واحد، فأصيغها أنا صياغة أخرى بعد إذن السائلين والحاضرين وأوجهها إلى السادة المتحدثين الكرام. أبدأ بدكتور أشرف لو تكرمت. This is a question came from saying, does all patients with diabetic peripheral neuropathy are symptomatic? And he doubt maybe he will say no. And if you will say no, how we can detect them?
Okay. First of all, I would like to thank very much the one who gave us these wonderful questions, because this will highlight a very important issue that is related that 50% of patients with diabetes, diabetic peripheral neuropathy, they are asymptomatic. So, but in fact, they have lost certain sensation like the proprioceptions, other perceptions like the pinpricks and the perception of touch and so forth. So with this, this comes, the importance of early screening of those patients. And as has been stated by my colleagues in their presentation, that early detections of those cases might improve the early handling of these patients and prevention of the severe complications. So that's why we use the monofilament tests in each examination when we examine our patient with diabetes in our clinic. So we make sure that the protective sensation is not lost. So once it's lost, this will highlight that there is a problem related to the perceptions of the feet. Plus the DN4 questionnaire, that the one I have mentioned, where there is 7 questions and 3 clinical examinations, will give us a very high probability of the diabetic peripheral neuropathy by almost 90%. So we have to make sure that there is about 50% of our patients with diabetes, they need our intervention. They need our high level of suspicions to detect their early stage of diabetic peripheral neuropathy even before the symptoms take place, and then we can take all the preventive measures as we have stated in the presentations.
Thank you. I hope this is clear for the people who ask about this question. And now I will shift to Dr. Khalid Idris. Dr. Khalid.
تفضل.
What is the bio انت داخل بمرتين في معانا؟
ما اعتقد.
انا شايفك هنا وشايفك بدون صورة.
بالله.
والله شايفك مرتين.
غشامة من عندي يمكن.
لا شطارة هذه.
طيب.
طيب السؤال اللي جاء في الحقيقة برضو أنا أكرر بإني أنا بحاول أجمع أكثر من سؤال وأدمجهم مع بعض وأصيغهم صياغة أخرى. What is the biomechanical effect of the foot amputation?
طبعا هو سؤال رائع وكبير جدا. خلينا نركز على البارشال فوت امبيوتيشن نسيبنا من الميجر امبيوتيشن. الترانسميتاتارسال امبيوتيشن في اغلب الحالات بعد ما نحاول احنا نصل الى جرح نظيف نسوي تندن ترانسفيرز، لانه اذا خسرت البرونيال تندن فالقدم حصير فيها انفيرجن، لو خسرت التندنز اللي من الناحيه الداخليه حيصير فيها ايفيرجن. ففي افكت كبير جدا وتختلف من حاله الى حاله على حسب احنا ايش بنضطر انه احنا نشيل. وفي كثير من الحالات بعد ما تنضف الرجل نسوي percutaneous tendon Achilles lengthening اللي هي الأكيليز tendon. We need to lengthen it so that the patient is putting more pressure on the heel than putting pressure on the front of the foot, which will prevent new ulcers in the future. عشان كده a lot of these amputations result in ulcers again. The amputation and the wound healing is only 50% of the fight. The other 50% is preventing re-ulceration, and actually that's more difficult than healing the ulcers.
دكتور أحمد معايا؟ في سؤال وصلنا بيقول what is the difference between classic wound healing and the regenerative wound healing?
ده سؤال ممتاز جدا جدا. طبعا اساتذتنا موجودين وعلى راسهم الدكتور خالد. احنا في الكلاسيك ووند هيلينج we have a scar, we have keloids, we don't have hair grown back again after tissue degeneration. اما الريجنريتيف يرجع كل شيء زي ما كان، زي ما شفنا في الحالات اللي احنا عرضناها. اذا كان في شعر بيطلع، ما بيكون في الكيلويدز، بتكون السكين عباره عن بيبي سكين باك، بيبي سكين. احنا عرضنا حاله اسوان كانت واضحه جدا جدا، وغيرها. ده الفرق بين الاثنين.
اي شكرا. طيب انا اعود اليكم دكتور اشرف لو سمحت. في الحقيقه هذا سؤال يمكن مور براكتيكال من داخل قلب العياده، واحنا دائما عياداتنا بتشهد الزحمه الشديده في العمل. فهنا السؤال اللي بيطرح نفسه: how we could practically apply the screening for diabetic peripheral neuropathy at our busy clinic setup.
تمام. أشكرك على هذا السؤال. طبعا يعني first of all we have to implement certain guidelines and certain clinical pathway that could govern the clinical practice even within a very busy setup, because we should not compromise the safety and the safety of our patient and the quality of service that we provide our patient. So definitely for those patients to screen them, as I said, and I have said it while in a side talk, that we use the DN4 questionnaire just to identify those patients at risk of getting into diabetic peripheral neuropathy, as well as any physicians or nurse who is a registered nurse who is taking care of a patient with diabetes. She should learn how to elicit the protective sensation examination for the feet of the patient with diabetes by using the monofilament and using the vibration sensation. As I have said, the vibration sensation is the first sensation that is get lost in the patient with diabetic peripheral neuropathy, and this will be the first signal that the patient is getting into the complication of diabetic peripheral neuropathy, and then we can allocate all the resources and protect the patients and ensure the quality of life of patients by reducing the hemoglobin A1C, by treating the other comorbid conditions, by improving the quality of life of patient, by having a multidisciplinary team approach to look into the patient from different angles to improve the quality of his life.
في الحقيقة برضو إذا تسمح لي دكتور أشرف إن أكمل معكم، لأنه هذا السؤال يمكن له علاقة أيضا. Is the nerve damage in diabetic neuropathy is irreversible, and how it could be prevented?
Okay. As we know that diabetes is a progressive disease, and most of the complication that happens, retinopathy, nephropathy, or even peripheral neuropathy, is to some extent it's irreversible. But we have to look into the patient with diabetic peripheral neuropathy that the small fibers of neurons, the C fibers, are getting impaired. And usually there is certain studies and certain trials stated that there is a possibility for nerve regeneration using certain molecules. And there's a lot of trials now by Dr. Don Ziegler from Germany, he's an endocrinology and pathologist who is very specifically working on these trials to highlight and reinforce that the possibility of regenerations of the C fibers in certain patients with diabetic peripheral neuropathy. It's not possible to regenerate, but it could be possible in the coming future once the trials exposed and revealed its results.
Thank you, Dr. Ashraf. I will shift to you, Dr. Khalid Idris. I think this question is coming from some colleagues who are practicing the podiatry medicine, and they are feeling something. They are asking about why do we see many failed transmetatarsal amputations with exposed bone?
Yes, this is what I mentioned in the presentation before, is for my colleagues, the surgeons, to not to do the guillotine cut, which they just cut straight across and you have the bones sticking out. And then once you have exposed bone, you will have osteomyelitis. This is poor surgical. It is just simply poor surgical training. It's usually what I say, it's somebody did the surgery who is a very good surgeon, but is not a diabetic foot surgeon. if a patient doesn't have diabetes and doesn't have a poor circulation, you do the guillotine cut, which is the classical cut for transmetatarsal amputation, and within a few days, granulation will grow and then epithelialization will close it. But this is not the case with diabetic foot patients. They have microvascular and they have macrovascular disease. And remember now, the more distal you go, the closer you're getting to the microvasculatures. So a transmetatarsal amputation usually gives you some trouble. It doesn't heal very fast. And as we saw, there are many studies that mention that. So making the situation worse by cutting it straight down and keeping the bones out, you're setting the patient up for a much higher amputation. And I think that's why we see a lot of the failure. Usually what I tell the patients is, please allow me to take 2 centimeters more of bone so that I can have enough skin, so that maybe in a second surgery or a third surgery, we can close the front of the foot and you go walking. Whereas if we just cut it, boom, like that, that's a disaster. And that's why we have a lot of failure.
نعم. طيب إذا تسمح لي برضو دكتور خالد أكمل معك أيضا سؤال آخر. السؤال هذا يمكن شائع كثير، وإذا كان صاحبه بيسأل عن نوع فهنالك أنواع كثيرة قد يتساءل عنها. خلينا نطرح السؤال كما هو. Is there any rule for honey, and he means bees honey, in healing of diabetic septic wounds?
The simple answer, the non-politically correct answer is no. I'd rather, seriously, and joking aside, I'd rather go for something with silver than to go with honey. There's no question about that. The reason why we say no honey بغض النظر انه فيه شفاء، لانه فيه شفاء مبهمه وليس معرف الال، ما فيه ال شفاء. العسل وبالذات ما ينفع يقولوا لي حر من المعسل. It's ours, it's from our own farm. It doesn't matter because it's contaminated. Why do we use Manuka honey? Manuka honey is the only honey that is acceptable because it's been sterilized by radiation and it has been studied. So every time you use Manuka honey, you know what is it that you're using. But if you take honey from the supermarket or you take honey from your farm, you don't know what you're using and it has microbes in it. All that honey does is it maintains a moist wound environment, and it has some osmolarity properties, and that's it. Yes, it has a rule, but in the hands of a foot surgeon or a podiatric surgeon, a wound care nurse, somebody who knows exactly what they're doing and they have good success with honey, they have studied it, they're using it the proper scientific way, then yes, they can use honey. But anybody else, no.
وليس الاستخدام الذاتي في المنزل.
ولا ذاتي ولا يعني
نعم.
بدون ذكر اسماء، في عيادات كنت اروحها تفك الدولاب تلاقي الغابه السوداء على مدري ايه، قوارير. هذا خطا طبي.
نعم.
العسل اللي نستخدمه عسل طبي من شركات طبيه. ممكن المملكه العربيه السعوديه الى قبل سنتين تستورد، وانا كنت في اللجنه، ب8 مليون ريال عسل طبي. واي؟ واحنا نعرف انه في شفاء من 1400 سنه عشان احنا ما سوينا research and development عشان احنا we do our own honey products. So yes, we can use honey as long as it's a medical grade from a medical pharmaceutical company and its effects have not been so great. احسن من بلاش. Let's just put it this way. احسن من بلاش بس برضه يكون طبي.
برضه في سؤال خليني معك دكتور خالد لو سمحت لي. في حالة وجود قرحة عميقة وصلت إلى العظام وتكسرت العظام أو تآكلت، يعني حصل destruction of the bone. Is it an indication for amputation?
برضو يعني دائما لما تشوف CNN ولا الأخبار ما يقولوا no yes بس I guess in science we have to say no or yes. The answer is no. It depends on how much bone destruction you have. This is where salvage comes into play. So if you looked at the indications for the forefoot or the midfoot amputations, if you have osteomyelitis in, let's say, the third metatarsal only, remove the third metatarsal and the patient will still walk. You can remove half the foot. You can remove a lot of things you can remove. If you have osteomyelitis, we need to remove that part surgically by precision. We don't remove a lot. We don't remove anything that is not infected. And of course, the discussion between surgeons and infectious disease doctors is huge on whether we can actually heal osteomyelitis with long-term antibiotics. And I think the consensus that's coming now is we need both. We need resection of infected bone and we need long-term antibiotics both to work together. That's why you need a team. But osteomyelitis on its own is not a direct indication of amputation.
Very clear. Thank you very much, Dr. Khalid. I will shift to you, Dr. Ahmed Al-Sawah. What is the main reasons for non-healing wounds?
Actually, as I presented from the paper of Dr. Ennis William, again, who is the president of the American College of Wound Care and Tissue Repair, that the main reason is the persistent inflammatory state. So the more we keep the wound inflamed without management, actually it will never be healed.
نعم.
Yeah.
طيب شكرا دكتور أحمد. I will be back to you دكتور أشرف. في الحقيقة يعني هذه أكثر من رسالة كانت بتيجي أو سؤال من زملاء في المهنة. حقيقة متشكرين جدا ولا بد أني أنا أذكر الكلام ولكم جميعا. ترى إذا قلت الآن الشكر للدكتور أشرف فكل رسالة تأتي ولو فتحنا الآن صفحة الكويستشن أند أنسر والشاتنج نجد الشكر الجزيل والامتنان لجميع المتحدثين في الجلسة الأولى على كل ما قدموا من معلومات جيدة تفيد مرضانا وأيضا الأسرة التي فيها مريض سكري نحو كيفية التعامل مع التقرحات السكرية. دكتور أشرف, how can we manage our patients with the painful diabetic neuropathy? That is, what the strategy you can put it for them?
Okay,
they can follow.
Thank you very much. This is a very prevalent question. We can encounter on a daily basis of this kind of clinical challenge. Of course, once the patient is diagnosed to be the patient with painful diabetic peripheral neuropathy, so he has a lot of pain, a lot of burning sensation, a lot of pins and needles and pricks, and he cannot sleep, he cannot concentrate, cannot lead the normal daily activities. So usually, first of all, after the diagnosis, we treat diabetes very aggressively, so tight glycemic control. So we look into the management plan and try to initiate a better way of management. And usually if the patient is on oral hypoglycemic agent, we shift to insulin or GLP-1 or SGLT2 or the new molecules that give us a more possibility to reduce the A1C in a very smooth way. And then we have to treat the other comorbid conditions, like if the patient is a smoker, if the patient has dyslipidemia, he has hypertension. We treat all these conditions, and then we start the medication. The medications, which is proved by the FDA, and even it's approved by the Saudi FDA for painful diabetic peripheral neuropathy, is pregabalin, gabapentin, tricyclic antidepressant, and duloxetine. So these medications, some of them, they are antidepressant medication or anticonvulsant medication, anti-epileptic medications. So we have to customize based on the patient profile. If the patient is elderly patient, I should not give him tricyclic antidepressant because of the anticholinergic actions of the tricyclic. So he will have a postural hypotension, retention of the bladder, drive in the mouth, but I might use pregabalin or gabapentin or even duloxetine. Patient who has a diabetic peripheral neuropathy with depression because of the pain, I will use a duloxetine for him because this is antidepressant, which is also proved to be very efficient in painful diabetic peripheral neuropathy, and so forth. So as I said, 30 to 50% reductions in the pain will be counted as a successful way of management of the patient. And here, very important point is that we have to reach to a common shared understanding and expectation. So the patient, when he comes to you, he feels that if you give him the medications, he will have 100% relief of pain. No, 30 to 50%, this is the maximum we can reach. But of course, you have to ask the patient to do some sporting, walking, and weight reductions and others. So this is the full strategy where we can enhance the better quality of life and the good control of patient with diabetic peripheral neuropathy.
شكرا دكتور أشرف. هذا السؤال لكم دكتور خالد إدريس. What is the role يعني أنت دائما بتؤكد على عمل فريق متكامل خاصة عند أخذ أي قرار يعني كبير بالنسبة لحالة المريض. ولكن هنا السؤال فقط about the infectious disease specialist. What is the role of infectious disease specialist in diabetic food salvage?
The doctor of infectious disease has a very big role in the team. لحد ما يعني الآن صار أغلب المستشفيات فيها infectious disease doctors وفي كل مستشفى infectious disease policies. لأنه البكتيرياز اللي تكون يعني إحنا ممكن نقسم البكتيرياز للأمراض. diabetic foot ulcers لها بكتيرياز تيجي more than others, but certain hospitals tend to have more bacteria that are living within the hospitals. That's why you need infectious disease doctors in the hospitals. You need infectious disease doctors to be involved with almost all infections because they're the ones who know I can treat infection, of course, but I'm not a specialist. So in the presence of an infectious disease doctor, he or she should be part of the diabetic foot team. There's no question about it. And the results, there are many studies that show that having an infectious disease doctor being part of the team improves outcome tremendously. So yes, it's a huge, infectious disease doctor is a huge part of the diabetic foot team.
شكرا يا دكتور خالد. آخر سؤال أنا أعتقد عشان لا نتجاوز الوقت المحدد للندوة لكم سعادة الدكتور أحمد السواح. Why Tetra Silver technology represents a new era now in wound care management, especially in the diabetic foot ulcers?
Okay, this is a very good question because before this technology came to light, there was the silver. The silver is monovalent. The silver is ionic. Whatever dressing containing silver is working by 1-to-1. One silver atom versus one bacterial cell where they steal the electron from the bacterial cell and then the bacterial cell is killed. So you need thousands and thousands of silver atoms on the dressing. It reaches minimum of 3,000 parts per million in one dressing in order to be able to kill as much as bacterial cells. This situation is not there at all in the tetrasilver tetroxide technology or tetrasilver technology because it's non-ionic. This is number one. Number two, it doesn't kill by touch. You need very low concentration of 10 ppm to 30 ppm maximum in order to eradicate thousands of bacteria through its unique electromagnetic resonating energy power. And on top of all that, for the regular silver, you need to stop in after 21 day or 28 day for you have to make some kind of wash out till you use another dressing. But for tetrasilver technology, there is no time limitation. You can use it all the time because it is non-ionic, it doesn't react. And that's the big difference between how it will represent to us a future.
شكرا لكم. مشاهدي الكرام، حضورنا الأفاضل، يا من تجاوز عددكم الآن 1800 أمامنا على الشاشة. بهذا تنتهي الجلسة الأولى لندوتنا عن القدم السكرية ومستجدات العلاج. أشكر السادة المتحدثين في هذه الجلسة، سعادة الدكتور أشرف أمير، سعادة الدكتور أحمد السواح، سعادة الدكتور خالد إدريس. وقبل أن ننتقل إلى الجلسة الثانية، وأود أن أعود فأذكركم بأن هنالك مسابقة إن شاء الله سوف نطرحها في نهاية هذه الندوة في جلسة المناقشة العلمية بعد الجلسة الثانية، وقد رصدت لها مجموعة هدايا قيمة. الفائز الأول سيحصل على جهاز أبل آيباد، الفائز الثاني والثالث سيحصل كل منهما على سماعة أبل إيربودز برو. نتمنى لكم حظا سعيدا لكم جميعا إن شاء الله تكونوا فائزين. بالنسبة لمن يتساءل عن شهادة الحضور وعن الساعات بإذن الله سوف تضاف إلى حساباتكم في الهيئة السعودية للتخصصات الصحية اعتبارا من يوم 20 من شهر يناير الحالي. وبالنسبة للشهادة نرجو منكم الدخول على الواتساب على الرقم التالي 0550565619 وتسجلوا أسماءكم باللغة الإنجليزية واضحة وكما تشاءون أن يظهر الاسم في الشهادة، وأن يكون ذلك خلال الندوة وقبل انتهاء أعمال الندوة في هذه الليلة. الشهادة ستصلكم في خلال 3 أيام إن شاء الله. الآن مشاهدي الكرام ننتقل إلى the second session in our symposium. المحاضرة بعنوان تقنية تترا سيلفر technology beyond instructions for uses. يسعدني ويشرفني أن أقدم المتحدث في هذه المحاضرة سعادة البروفيسور مصطفى سليمان. Professor Sulaiman is a professor of vascular surgery in Ain Shams University, Egypt. He is executive board member of Vascular Society of Egypt. He is advisory board member of Bayer Pharmaceutical and Sanofi Pharmaceutical. Currently, he is the head of vascular surgery department in Ain Shams University. Professor Mustafa Sulaiman is coordinator of quality assurance for vascular surgery department. He is the supervisor of postgraduate education for vascular MD program. Previously, he worked as consultant vascular surgeon at King Abdul Aziz Specialist Hospital in Taif, Saudi Arabia, and worked as a director of vascular surgery unit in Ain Shams University Specialized Hospital in Cairo, Egypt. Also, Professor Mustafa Sulaiman has a large experience in Europe. He worked as a vascular and endovascular surgeon at Saint Joseph Hospital, Marseille, France. Also in Utrecht University, Netherlands, and in Louvain University in Belgium. He has many publications in vascular and endovascular surgery in national and international journals. Professor Mustafa Sulaiman, you can share your presentation now, and you will have 25 minutes starting from now.
Okay. Okay, you hear me now?
أيوة اتفضل.
Thank you very much for your magnificent presentation for me, and I'm really honored to be a part of such an elegant meeting today with our professors and doctors from Egypt and Saudi Arabia.
You are most welcome.
Thank you very much. In my presentation, I will give an overview regarding our experience with the use of nanosilver technology or tetrasilver technology. So I want you to let me, or excuse me, that I will take the whole presentation talking about this technology and how we use it in our patients. The title of my presentation is tetrasilver technology beyond IFUs or beyond instructions for use. And I think this title will be explained by itself by the end of this presentation. Chronic foot ulcers that are difficult to heal due to unsolved problem in its anatomy, as those affecting weight bearing or blunter aspect, or those at a mobile joint area. Also, untreated underlying pathology can prevent healing or even complicate the situation more. Moreover, we cannot forget the role of immunodeficiency, either due to autoimmune diseases or debilitating conditions. After tackling all these factors, that we have to look for a wound care material that can overcome different kinds of infections, promoting healing, and at the same time, it must be safe and easily used by the patient himself at home in a shorter time. So, if we can get a smart product containing high concentration of oxygen that can emit very high energy enough to kill most of pathogens at the field, and then increase and recruit the stem cells to cause tissue regeneration without a fibrous scar, this product will be a regenerative factor causing recruitment of new normal tissues rather than fibrous bands. So if we had such a material, we will not dream of something better. So we decided to test this material in some of our cases with diabetic foot ulcers. When we started with small, easy cases like this one, a bit sore with excoriated skin for a long time in a bedridden paraplegic diabetic patient. And we use this product and we got complete cure with healthy skin within only 1 week. As you see, the skin is almost completely normal. After that case, we tried with a diabetic toxemic patient with huge intramuscular leg abscess. And within only a month period, we had complete healing with no scar tissues, as you see. So after that, we go a step forward. We used it with a case of plantar ulcer. This is a case we shared with some colleagues in other place. And you see healing was complete in only 3 weeks with normal skin at the plantar aspect. Again, in a resistant neuropathic ulcer, after surgical debridement and protruding bone excision, healing was complete with the use of tetrasilver as a sole agent of treatment. You see here at the last picture, it's normal. After these results, we decided to go further, and more challenging cases were recruited to be used with to be exposed to this technology, such as this 11-year retarded boy who suffered from this lesion for the last 4 years. His tissue biopsy was inconclusive, and we don't know what is the pathology behind. We failed to convince him to debride this mechanically and surgically. He refused and insisted not to be touched. So we tried, and we were obliged to use tetrasilver alone in such lesion for a twice daily dressings. And you can see it's better and better. Day by day, it's almostly healed with normal skin. In only 14 weeks, we got this result. And this boy regained his walk again on his own feet. That's why we decided to document this success by starting a randomized controlled study in our center, comparing it with the standard. Then we published our results 2 months ago and concluding that nanosilver technology proved to be an advantageous solution, especially in desperate cases, to avoid amputation or at least lower down rate. And here another case with extensive fasciitis in a bedridden, debilitated 8-year diabetic. We did a mechanical debridement as usual. Here, and then correctage of the wound bed to be ready for dressings after that. After that, for the next 3 weeks, the patient was undergoing dressings by his own with classic dressings, as he refused to use this new technology because his son was a doctor and he refused to try the new technology. And you can see the result after 3 weeks with bad wounds and no healing at all. After that, he convinced to use our technology application, and you see within less than 1 month, very, very healthy granulation, and it is ready to be healed. Another case with a diabetic hypertensive toxemic female patient with infective gangrene of right forefoot and extending infection through plantar fascial planes. Her X-ray showed osteomyelitis of the 5th metatarsal bone. So extensive debridement was done, taking full thickness of the partial thickness of the foot, with excellent results with these products. Again, with a case of bilateral vasculitic ulcer in a heavy smoker 40-year male patient, it was difficult to heal, and we started this product for dressings. We see better and better result and complete healing with normal skin. This success was nice and encouraged us to tackle more deeper problems. This lady was advised, as usual, in such cases with osteomyelitic infection of the big toe, to go for amputation of this toe. She came seeking for another solution to avoid losing her toe. As you see, the osteomyelitic changes of the big toe bone. We adopted the new technique. A new technique here, it is beyond the instructions of the company, that we started to even after debridement and excision of the osteomyelitic bone, we inject deeply the drug itself inside the wound. As you can see. And this is during follow-up of the case. And to be repeated on a weekly basis by injection of this drug. And this is a follow-up pictures of her lesion. And this is the final picture of the toe, almost normal toe. And here there is no osteomyelitic changes. This is a case Dr. Ahmed Sawah showed us earlier. It's a very interesting case with refractory traumatic, with refractory healing ulcer due to underneath osteomyelitic changes at the base of the big toe, as you can see. Same technique was applied by injection deeply in the wound, the tetrasilver solution. And this is the follow-up pictures ended by complete healing. This is another interesting case with refractory traumatic ulcer at the ankle started 43 years back. The trauma dated 43 years back, and with this continuing annoying ulcer with severe pain for 43 years, no response at all to all kinds of dressings. Although all through this period, he was in severe pain, taking tramadol every night to be able to sleep. He lost his job as a driver, of course, and we offer him this new technology. We did extensive debridement with excision of all necrotic tissues and tendons, with injection of silver at this deep exposed bone area. And this is the follow-up pictures. And of course, his pain was alleviated shortly after, and he didn't use any more tramadol tablets. And we reached this result in only 100 days, with complete healing, with normal skin, and the patient regained his limb and regained his normal life. This is another category of cases. His left ankle was like a bag of pus in a toxic diabetic patient due to infected charcoal, and this was his fate. This is after complete of management, his ankle was like this. Passing through these steps after debridement, injection at the site of wound, till complete healing, as you can see. And this is his testimony. I hope you can hear it. This is another case, but with more severe infection of her left ankle Charcot. With the same technique, we applied the same technique. You will see here, we'll do debridement of all necrotic tissue, drainage of pus, and curettage of the tissues thereafter. Curettage of the bed. The other wound on the other side of the foot. We get rid of all necrotic tissue. All pockets of pus must be open drained. The blunter aspect lesions also debrided. And then injection of the nanosilver solution inside the wound. Again, I will repeat, this is not the instructions for use of the drug, but we dreamed to make something a breakthrough, and then spray the solution over the raw area. And this is here follow-up pictures. As you see, the blunter lesions healed completely, and these lesions with still with to be have some time, but you see the very healthy, good granulation tissue, and the edema subsided, and the patient pain disappeared. Our last case today, again with infected Charcot ankle in a miserable young girl, 18 years old with juvenile diabetes, presenting with destroyed ankle, as you see, and ugly offensive refractory ulcers. She came to my clinic to get rid of this foot. Watch the big discrepancy between both sides. We did the same technique with debridement of the tissues, bone fragments excision, silver injection, and twice daily dressings. And this is a session of injection, and you will see the technique of dressing.
Prof. Mustafa Sulaiman,
Yes.
you consumed already 20 minutes.
Yes,
and
I have still.
Still you have 5 minutes.
Okay. Okay.
Okay. Go on, please. Thank you.
I'll finish before 5 minutes. You see here, no collections at all, no edema. The wound almost healed. The bone, the exposed bone was covered. And the injection of the solution. And these are the follow-up pictures. Here you see the shape of the foot and the edema disappeared. And here is the complete healing of the wound. She regained almost 100%. And to conclude, safe and healthy regeneration is the most important point we are looking for, is the regeneration. Thank you. Thank you, Dr. Hafiz. I finished my presentation.
شكرا بارك الله فيك بروف مصطفى سليمان. في الحقيقة
in 21 minutes.
Yes, thank you very much for that. Maybe you can grant it to the next speaker if you like. Thank you very much.
Okay.
And
of course.
Now I'm going to introduce the next lecture. عنوان المحاضرة دور الغشاء الأمنيوسي البشري في علاج جروح القدم السكرية. The role of a human amniotic membrane in diabetic foot ulcer management. The speaker is Dr. Nashat Ali Ghandura. Dr. Ghandura, he is a consultant in general surgery and diabetic foot. He is the head of diabetic foot unit in King Fahd Hospital, Jeddah, Saudi Arabia. And Dr. Ghandura was the one who established the first diabetic foot unit in the Ministry of Health in Saudi Arabia, and it was on 2008. Dr. Ghandura is the vice president of Diabetic Foot Committee in the Ministry of Health and a member in Technical Committee of Diabetic Centers in the Ministry of Health. He is the founder and a member in the Gulf Diabetic Foot Working Group. Dr. Ghandura is a member in the European Wound Management Association, and he is a speaker and attendance in national and international diabetic foot conferences. Dr. Nashat Ghandura, welcome, and you can join now your presentation, and you will have 25 minutes starting from now.
بسم الله الرحمن الرحيم الحمد لله رب العالمين والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا محمد وعلى آله وصحبه أجمعين. First, I would like to thank Dr. Abdul Hafiz Khoja for this nice presentation and presenting me. And I would like also the company and the organizing committee to give me this opportunity to share with you our experience in management of the diabetic foot ulcer. This is our hospital, King Fahd General Hospital in Jeddah. It's about 700 beds, about 42 years old. And we have most of the all subspecialty need in our units. And also I established the first unit in Ministry of Health for diabetic foot units. And this is the King Fahd Military Hospitals in Jeddah also. And this hospital also, they have units of wound and diabetic foot units. And we did this study together. We have an agreement between me and Dr. Muhammad Baghdadi and Dr. Tawqir Ahmed to do this study about using of the amniotic membrane in the management of the diabetic foot ulcer. Now we'll talk about the history of the using of the human amniotic membrane. In 1910s, Davis did a review of cases at the Johns Hopkins Hospital using the fetal membrane as a skin substitute. And Stern and Sabila reported using the fetal membranes to the treatment of the burn cases and also chronic ulcer skin disease. Well, it was in 1900. Early adopters of this material noted that the human amniotic membrane improve the controlling of the pain, infection, and healing properties, and were later confirmed. In another studies, we believe that it's related to the underlying molecular biology of the material. Chronic non-healing wounds appear in various types of the patient. As you know, diabetic patient, about 15 to 20% of these patients developing the diabetic foot ulcer. Also, post-traumatic and surgical wound can be also present issue with the delay closure or development of the chronic wounds. There is multiple factors affecting wound healing. As you know, there is the age, genders, obesities, immobility, infection, and smoking also increase the risk of the non-healing wounds. It has been reported that the amniotic epithelial cells secrete angiogenic factor as vascular endothelial growth factors, interleukin 8 and interleukin 6, angiogenin and interferon, basic fibroblastic growth factors, and epidermal growth factor and platelet-derived growth factors. It has been used as a biological dressing for burning case or acute and chronic wound, chronic leg ulcer, including vascular ulcer, and for example, and also for diabetic foot ulcer. It's reported that it's used in the head and abdominal, pelvic, and cardiac surgery for prevention of the tissue adhesions. Also used in the dental surgery for dental sockets. Used in gynecological surgery, for example, for using for the reconstruction of the new vagina, and in neurosurgery to treat and to repair the dura mater, and also in ophthalmology surgery. As you know, the amniotic membrane have two layers. It's amnion and corneum. The amnion, which is the inner layer close to the fetus, and it is the thin layers. It consists of the epithelial cells anchored to the basement membrane by compact collagen-rich tissue. The second layer, which is the thick layer, and it is the outer layer close to the mother uterus. It consists of the dense collagen fiber. The corneum is 4 to 5 times thicker than the amnion layers. Neither the amnion nor corneum are vascular. Human amniotic membrane, or as mentioned, the amnion, is the uppermost non-adherent ectodermal layers of the placenta that is facing the fetus. As you can see here, this is the layer, this is the amnion layers, which is, it's faced the fetus, and this is the thick layer, which is outer and facing the uterus. It has the amniotic layer, it has a single layer of cuboidal epithelial cells, thick basement membrane, and a vascular stromal tissue, and it is loosely attached to the cornea. This is the layer of the amnion, and this is the loose stromal attachment layers, and this is the corneal layers, as you can see here. Amnion layers, there is amniotic epithelial layers, and also there is amnion mesoderm, And in the corneum, there is corneum, mesoderm, and corneum trophoblast layer. And amniotic membrane has a certain specific characteristic that non-immunological reaction due to lack of the HLA A and B and C and DR antigen. It also has a cell migration and growth promoting activity like cytokines, growth factors, protease inhibitors, and it can be preserved in minus 80 centigrade up to put a protocol for how to start the stable. So just to see if there is a seronegative in the donor and recipient, hepatitis B and C and HIV A and 2, number 1 or number 2, and syphilis. We have to get the consent from the donor and from the recipients. And there is a protocol to how to do harvesting of technique for the amniotic membrane from the placenta, cleansing and preparation of the methods for the amnion membrane, patient selection criteria. We put also dressing protocol, follow up in the clinic, and the result after that. So we started. Actually, our amniotic membrane usually will take it from the cesarean cases, and after the baby delivers and the placenta delivers, then we have to separate the amnion from the corneum. As you can see here, this is the amniotic membrane, this is the corneum, separated, and we cut it. This is our colleague, Dr. Muhammad Bughdadi from Military Hospital. And then after we do cleaning processing by normal saline and remove all the debris and the blood clotted, then we put it in a special containers, sterile container with gentamicin, about 160 milligram gentamicin in each container with a normal sterile normal saline, and then we label this container and we put the date of the cesarean section and the name of the patient. So this study done in our hospital, King Fahad Armed Hospital. We did about 68 cases. Half of them is diabetic food, about 35. And there is some cases, acute cases like crush injury, 7 cases, burn case in 14, pressure ulcer, 8 cases, and post-operative 4 cases. Now we'll see some cases done in our hospital and also in military hospital. This is a 59 years old male diabetic patient, hypertensive, hyperlipidemia, and also post femoropopliteal bypass. After bypass surgery, he has normal ankle brachial index. The patient developing of an ulcer after fifth toe amputation, and there is a non-healing wound at the lateral dorsum of the foot. X-ray showing there is no osteomyelitis, and we did multiple session of debridements, and tissue culture, it was negative at that time. And then after local debridements, remove of the necrotic tissue, we apply this amniotic membrane. Usually we take a side of the sticky side. We have 2 sides of this amniotic membrane. One side is a little bit sticky than the other side. So we can apply directly in the wounds, the face of the wound, and after that we apply non-adherent material over the amniotic membrane to prevent any effect of the dressing. So we are doing the dressing twice a week as outpatient, and after, this is the picture after first week. Start the wound become smaller, get less in the size, and it was still the amniotic membrane intact, no collection underneath, no pus, and no sign of inflammation or any reaction. This is after 4 weeks. You see the difference in the size, get smaller, shrinking in the wounds, and this is after 8 weeks. There is no wounds and have a good outcome. And the patient, after following us in the clinics, after 6 months, there is only scar you can notice in the foots. Next case is a 64 years old male patient, diabetic, hypertensive, and also he had wound in the dorsum of the right foot since 2 years, chronic ulcer, doesn't heal, and he has normal ankle brachial index. He offered in outside our hospital for amputation of the foots, and when he came to us, I did multiple sessions of the debridements, remove part of the bones of the tarsal bones, and after that we apply him VAX system in this wound. Then we offered for him using the human amniotic membrane. This is after we applied the first visit. After 2 weeks, as you can see, the wound becomes smaller and get less in the size. This is after 4 weeks. It's the same, it's become lesser, and the deep opening or the depth of the wound has become superficial. After 8 weeks, about 70% of the wound is healed, and after 12 weeks, it's completely healed. This patient following us in the clinic, after 4 months, it's only the scar of the wound and no more ulcer at that side. The third case is 59 years old male diabetic patient, and he presented with the infected fifth toe since 1 week. We remove partial amputation of the toes. You remove the distal bone, distal phalanx. He has normal also there
دكتور
is no
اشرف الصوت
significant
عندك
growth.
بيقطع.
And then
دكتور غدوره،
الصوت واضح الان ولا برضه؟
الصوت عندك بيقطع كثير.
يمكن
ان شاء الله يكون
الرسالة
واضح زي ما بدات في البدايه.
الان دكتور عبد
Continue,
الحميد.
please. Go on.
طيب. And then after
ان شاء
we
الله طيب
apply
الان.
ممتاز الحمد لله. We apply the amniotic membrane in the stump of the fifth toe. We did dressing twice a week, and this is after 2 weeks. The wound is become less, and the third week also there is the wound is about 50% less, and after 5 weeks up to the 8th week, the wound is healed. This is after 10 weeks, completely heals the wounds. Fourth case, this is a 45 years old male diabetic patient. He has a wound in the dorsum of the right foot since 4 weeks, and normal vascularity, X-ray, there is no bone involvements. but there is some infection. We did for him multiple debridement sessions, and after he has good granulation tissue, and we take culture, and there is no significant, and you know, most of these cases contaminated infection, so we can apply the amniotic membrane in that cases. So after we offer for him amniotic membrane, and after first week, you can see now it's improving the shape of the wounds, and the debris is become less. In this case, I applied the amniotic membrane for second times in the second week, and started to have less in the shape and the size of the wound, and also become superficial. This is after 3 weeks. After 5 weeks, 50% or 60% less in the size, and after 7 weeks is completely healed. This case actually in the military hospital, this patient is an 83 years old male patient, diabetic with CVA and bedridden, hypertensive, complaining of the pressure ulcer at the sacrum, stage 3 to 4, and X-ray, there is no bone involvement. Culture, there is moderate growth infection of the E. coli. Initially, we start, Dr. Tawqiri start initial debridement and start the treatment of this ulcer. And after that, until become superficial, the bit sore, the ulcer. So we offer for him is to do a human amniotic membrane, and twice a week. Then we apply a vac after we apply the human amniotic membrane. This is the human amniotic membrane, and after that we apply vacs and change it twice a week. And unfortunately, we don't have the picture in between, but this within 5 weeks is completely healed. The last case we are using in the acute case, in the acute injury. This 23 years old male patient sustained human bites at the right supraorbital area. After cleaning of the wounds, we offer him to apply an human amniotic membrane and twice a week to dressing. After 3 weeks of the applying of the human amniotic membrane, the wound is completely healed, and after 6 weeks, you can see the scar become less than before. So, in conclusion, that human amniotic membrane is facilitate epithelialization, it's maintain normal epithelial phenotype. Infection and rejection of the graft are very rare, and about our cases, about 95% of our cases healed and no sign of rejection. Reduce scarring and also reduce inflammation and pain, and also reduce tissue adhesion, reduce exudates, has antibacterial properties, and provide natural biological barrier. It is inexpensive. It's available. That is easy to harvesting and available in any general hospital with the obstetric and gynecological departments, and easy to harvest, easy to apply. The disadvantage of this raw human amniotic membrane is that the storage is difficult, and sterilization and availability. This is our reference. And in the end, I would like to thank you and to thank all the organized committee. Thank you very much.
شكرا جزيلا لكم سعادة الدكتور نشأت غندورة على هذه المحاضرة القيمة. وفي الحقيقة أنا أميل كثيرا شخصيا للمحاضرات التي تحمل الجانب العملي إلى الجانب النظري. هذه من واقع الحياة، وهذه الحالات تعكس لنا العمل الحقيقي بالزمن وبالتطبيقات وبالنتائج. في الحقيقة أنا أشكركم شكرا جزيلا، وأيضا على التزامكم بالوقت المحدد، وإن يعني باقي لكم عندنا تقريبا دقيقتين ونص، ممكن تديها للدكتورة ثريا السبيكر ذا نكست سبيكر على أساس إنها تاخذ راحتها شوية. شكرا دكتور غندورة، شكرا. مشاهدي الكرام، لازلنا نتلقى استفسارات عن موضوع الشهادة، وإحنا قلنا إنه الشهادة، شهادة الحضور تستلموها، تخشوا على الواتساب رقم 0550565619. في هذا الرقم في الواتساب اكتبوا اسمكم باللغة الإنجليزية كما تشاءون أن يظهر في الشهادة، والشهادة حتوصلكم إن شاء الله في خلال 3 أيام. أما بالنسبة للساعات التعليمية من الهيئة السعودية للتخصصات الصحية سوف تدرج في حساباتكم تلقائيا اعتبارا من 20 من شهر يناير الحالي. وأيضا لا أنسى أن أذكركم بأن هنالك مسابقة قيمة في نهاية هذه الندوة، وجوائزها أيضا قيمة. أبل آيباد شيء جميل جدا، يا حظ من ينول ويفوز، وأتمنى لكم جميعا حسن الحظ إن شاء الله والفوز بهذه الجائزة القيمة، وأيضا الجوائز الأخرى للفائز الثاني والثالث. الآن اسمحوا لي أن أقدم المحاضرة التالية، وهي بعنوان علاج غير تقليدي للقدم السكرية. Unconventional treatment of diabetic foot. والمتحدثة سعادة الدكتورة ثريا منصور طشقندي. سعادة الدكتورة ثريا طشقندي had her basic education at Lebanon and Egypt, and had her degree of medicine from King Abdulaziz University in Saudi Arabia. Then she got her diploma universitaire superior from University X Marseille or Do in France. يعني أنا ما بين الإنجليزي وما بين الفرنسي يعني شوية شوية. And she got the attestation certificate of associate attaché in plastic surgery department of Professor Guy Magalon in the Conception University Hospital, Marseille Do in France. Dr. Thuraya Tashkandi was a consultant in plastic surgery in King Fahd Hospital in Jeddah, Saudi Arabia since 2008 until 11th. Then she started her private work in a private sector as a consultant plastic surgeon till today. She is a fellow, board member, and treasurer of Saudi Association of Plastic Surgery and Burns. Dr. Thuraya Tashkandi is a fellow of GCC, Association of Plastic Surgery and Burns, and fellow of Mediterranean Association of Burns. She is a board member of Healthcom Company, Private Medical College and Hospital. Dr. Thuraya, she is a fellow of IFAT since 2018. What is IFAT? IFAT is the International Federation for Adipose Therapeutics and Science. Dr. Thuraya Tashkandi, you can share your representation now, and you will have 25 minutes starting from now.
Okay, Assalamu alaikum.
Alaikum assalam wa rahmatullah.
It's a pleasure to be with this great members of this nicely done virtual presentation. I will try to be very brief. We will start about the unconventional treatment of diabetic foot. As you already know, most of them they mentioned, my colleagues, more than 220 million people are affected by diabetes. The WHO projects that this number will be doubled between the year 2005 to 2030. Up to 6% of the patients with the DM may develop a diabetic foot ulcer, with over 15% requiring amputation. The fundamental goals of the plastic surgery is preservation of form and function. And the main objective is achieving a healthy, non-infected wound with an adequate perfusion and biochemical stability, aiming for a plantigrade functional foot without residual and ulcerative and recurrent ulcerative lesions. Of course, the modality of treatments, as my colleagues, they presented, we start with debridement, wound dressing with multiple choices. One of them are the silver that Dr. Ahmed presented. After that, the role of the plastic surgeon comes where there will be a skin graft or flaps. Flaps can be rotational, pedicle, or free. Also the use of the negative pressure wound therapy. Then we reach to the free tissue transfer fat, the stromal vascular fraction, and the platelets rich plasma. As you know, the fat is not a newly born technique. This is, I need to tell you about that. It started, it's really the uses of the fat transfer since the latest 19th century by a doctor known as Robert Gerusny in 1844 and 1924. Then Leonard Corning also. Both of them, they started using paraffin and Vaseline to modify the featural imperfection on a saddle nose and a facial wrinkles. But there were some complications as the injection caused a hard local swelling, which tend to migrate, causing pulmonary embolism. Then Eugene Hollander from Berlin. Then Gustave Nuber, the one, this is in 1893. He was the first to have the fat graft, where he transplanted parcels of adipose tissue harvested from the arm of the patient to the lower margin of the orbit, and he reported a very good result. In 1895, Vincennes published a paper about transferring a big-sized lipoma, taking from the patient's buttock and inserted into the left breast to replace the gland excised for a fibrocystic mastitis, and which the result was stable for about 2 years. Erich Laxer, he's an orthopedic and a plastic surgeon. He published his first book about the free transplantation and reported different clinical application in both reconstructive, functional, and cosmetic field. Placide Mauclair, the first in 1922, he published the first French book, Les Greffes Chirurgicales. He uses the fat around the tendons of the hands to restore gliding tissue and the greater omentum to repair a bladder defect. Also from the state, Harold Neuhoff in 1923, from Chicago at 1926, Charles Miller. Charles Miller is known as the father of cosmetic surgery, and he published a book about the cannula implants and review of implantation technique in aesthetic surgery. In 1950, Linden studied the growth and the microscopic appearance of the fat grafting after 1 year of transplant, and it was the first scientific investigation of fat graft survival, and he concluded that the adipose grafts loses approximately 45% of their weight and volume at 1 year after post-transfer, because the fat cell rupture and die, and those who did not rupture tend to survive. As for now, we know that when you inject the fat, 45% of what you inject, the volume, within the first 3 weeks, it will be gone. But the other 55, it will remain. It will remain. It will grow with you. It will, you lose weight, you will lose it. You gain weight, it will get bigger. A big single fat graft loses less bulk than a smaller multiple graft. The free graft, improperly handled during the operation, will fail to take, because you have to know that the fat cells are very sensitive to even the slightest amount of trauma during surgical operation. That's why it is very important to know the technique, the proper cannula to use in such, if you want to use this technology. The microscopic studies, it indicates that early revascularization is essential for the adipocyte survival, and that the fat cells do not tolerate ischemia. In 1980, Pierre Fournier and Yves Gérard Illouz, those are the persons who invented the liposuction. They both worked as an autologous fat injection, and they noted that complete resorption of fat, but they still recommended further studies. And we met them maybe 3 years ago, no, 5 to 6 years ago, and they are using now the fat in a proper way. Benzakouen and Chachouir they reviewed 253 patients over the 4 years, and they reported 86 favorable results with a fat injection for aesthetic as well as reconstructive procedures. 1990s, this is start the real era of using fat transfer. Sidney Coleman, he becomes more famous even due to his vast experience with the autologous fat transfer, and he re-emphasized the importance of the most atraumatic technique for fat harvesting and placement to preserve the fragile adipocyte. The Coleman's list for a key of success, as you know, some people, they do use the fat and they say it's nonsense, it's gonna get absorbed. It's not true. If you know the way, you follow the good key, you will have a great success. You have to use, according to Coleman, this is in 1990s, the use of 17 gauge cannula connected to 10 cc syringe. Of course, this all these keys now has been modified and changed with in the proper time. But the basic is to have a small cannula, not by a needle. You have to have either centrifugation or decantation. The minimal amount of fat you place it, and how to place it in an intricate nest or tunnels to superimpose layer to implant their vascularization. The first course in 1998 of the autologous fat grafting was organized in Marseille by Prof. Guy Magalon with conjunction of Sidney Coleman. And the lipostructure was introduced to France and used for different indication in plastic surgery. As you know, fat is a repair organ, and it is used now in regenerative medicine. As in addition to the fact of being a high energy reservoir with insulating property, it becomes apparent that fat is a repair organ providing the basis for soft tissue regeneration. The fat cells, the recent study, it shows that the extracellular matrix have shown that beside the adipocyte, the fat cells, it contains smooth muscle cells, fibroblast, endothelial cells, adipose-derived stem cells, and the adipose-derived stem cells itself are capable of differentiating into many other tissues like nerve, muscle, blood vessels. This ability to become another tissue allows the fat to enhance angiogenesis or even to replace damage or a missing cell. As you can see here, the stromal vascular fraction composition taking from a bone marrow compared to the taking from the fat cells, you can see that in the fat cells, it is 2,000 to 500 times greater than taking from the bone marrow. And easier and less painful and more appropriate, and it's taking from the patient himself. not like the amniotic fluid or the umbilical cord, which needs to be stored and sterilized and so on. I guess this is a good point for it. The adipose tissue and the stromal vascular fraction is unique. It is the only organ that undergo considerable changes in volume in adult, mediated by changes in the adipocyte cell size. Individual adipocyte can expand with weight gain, shrink with weight loss. The blood vessels within the adipose must lengthen or be prone to support increase or decrease the tissue volume. The stromal vascular cells in the adipose tissue are in a state of increased plasticity compared to those in other tissue. The fat tissue modification, yani when you take the fat, you have to take the fat liquefaction either by centrifugation or digestion. We used to use collagenase, but now it is prohibited for its reaction to get to the stromal vascular fraction. Of course, as I said, the cannula size is very important. The cannula of the harvesting, and then to inject, it have to be a specific diameter. It is not by hazard like that. And the syringe versus the pump, purification by centrifugation or by just spontaneous settlement. The technique of injection is very important. The type of the cannula, the spreading of fat, the way when you aspirate the fat and when you inject the fat, it have to be injected while you are withdrawing your cannulas out. It have to be in a channel. You have to be away from the muscle so that you will not create fat embolism if it will happen. The depth of injection is important, and there is a say about the storage of fat. Some people, they just take the fat and put it in their office, and then they could tell the patient, come after 3 weeks, we inject the rest. Of course, this is not appropriate, as the fat cell will die. You will inject dying fat cells, because the fat cell, at least minus 20 degrees Celsius, you should store it. Adipose tissue, we can take from it the stromal vascular fraction. Few years ago, there was lots of companies. Saitori is one of them, but it was very expensive. The devices they are using, the enzymes, the collagenase, which is now prohibited. By these slides, by this machine, I'm sorry, you can exaggerate or increase the amount of the stem cells, that pure stem cells that you can use later on in your wound or whatever you are using it for. Adipose tissues or the stromal vascular fraction, they are unique. They are obtained by enzymatic digestion, not any longer. They promote healing and repair in response to physiological stimulus. If you enrich your fat graft with stromal vascular fraction, this will increase your graft retention. If you enriching the fat graft with the stromal vascular fraction, cells will appear to reduces the number of treatment needed to obtain an aesthetically acceptable result. These property of the stromal vascular fraction cells are being exploited in a wide array of clinical setting. The future lies in manipulating the adipose-derived stem cells in your lipoaspirate, either by adding different products such as PRP, plasma-rich platelets, or insulin, or steroids, all of which will enhance the survival. And they found that the PRP and the stem cells, they are similar in that they are used, you are using it from your own body or the patient's own body, natural reparative factors to harness the healing resources to the body to repair the injured tissue. Both of which works by delivering a large amount of dose of the cell that secretes signal, which will boost the natural healing process in the body. But they differ, and some people, they use the PRP alone. The difference is that the PRP must be repeated many times to help recruit the stem cells found in the treated area. Whereas the stem cells procedures It delivers a concentrated amount of stem cells into the desired treated area. They do not only secrete growth factors and other intracellular signals to command and coordinate the repair process, but they also can replace, regenerate the tissue by themselves directly. As I said, the concept of using adipose-derived stem cells found in the SVF in your lipoaspirate or adding the other products will all enhance your regeneration and the regeneration of the tissue. This is one of the cases that we used from Dr. Mehmet Karantin in Turkey, the pre-operative 6-day post and 50 days post-operative complete healing. Here I would like to present the study of a colleague, Dr. Michael Karstnik from Nicaragua. I met him last year in the International Federation of Fat, the IFAT, and he represented some cases of ischemic leg with diabetes. I would like to show you the results. Of course, they show that in the United, the huge burden on the socioeconomic cost of the diabetic foot ulcer. In the United Kingdom, they found that 135 amputation weekly. They have this high percentage. They got the adipose tissue processing. I will not go through the details, the machines or what are the things that we are using, but basically you got your fat, you prepare your stromal vascular fraction from it in a closed, sterile, single-use system to avoid any infection. And then you process it. It will give you a big yield of cell to prepare the stem cells. This is a chronic limb ulcer in 10 patients treated with SVF. 10 patients aged from 57 to 85. 7 of them, the amputation candidates, seven were diabetic, 3 with atherosclerotic disease. Ischemia Rushford classification 6. The ulcer, it was a critical size more than 3. The transplantation to the systemic foot of 30 times 10 to the 106 stromal vascular fraction cells. The results were very nice. Ischemia was, the Rutherford was 1. The ulcer size completely gone. And the neovascularization was shown by angio MRI. Another 5, I will show you the picture. Another chronic limb ulcer was treated also with SVF over 48 months. 4 of them were diabetic, 1 is atherosclerotic, and also the results was the ulcer recurrence is 0, neoangiogenesis, patient was offload and increased the proximal flow velocity was shown. This is the cytorevascularization of a female of 64. She's diabetic, the Rutherford is 6. We had the same amputation toe within 1 to 3 with a non-healing ulcer of 5 by 4 centimeters for 3 months. After that, it will show you the months was after 4 months, the clean vascular uncontracting. This is after 4 months and after 9 months. And also, how do we inject? Do they inject subdermally around the periphery of the ulcer, the transplanter beneath the ulcer, periarterial on the dorsalis pedis and the tibialis anterior, and the wound after 4 months vascularized and contracting, and by 9 months, it's completely healed. This is the angio to show you the neovascularization. This is, and this is the patient after 3 years. She's at home, as Dr. Idris said, at home she can use her leg freely. This is another case, a male, 75 years, diabetic, with a Rutherford 6, the rest pain, extensive dry gangrene. The surgical wound was more than 6 by 4 centimeters. He was injected by SVF. After 2 months, intensive, you can see the intensive vascular response. After 9 months, closed with a stable skin cover. I would like to stress here that there were no skin graft, no vascular surgeon interference, and you can see his limited ambulation at home after 4 years. This is another case, bilateral ulcer, 4 centimeter by 3 centimeters, closed at 6 months of time. This is the bilateral, and the power Doppler show you the new vascularization. This is another one, right foot, 9 by 5 centimeter. Again, they will show you the neovascularization and by Doppler, the blood flow. And this is the right foot healed after 9 months. The observation was that the stromal vascular fraction is a long-lasting technology. The local neoangiogenesis remains stable. The SVF has multiple precursor cell population and some replication in situ of the cells. The SVF associated with proximal changes, they decrease the thickness of the arterial wall. They have no effect on plaque. They increase the flow rate. The mechanism of antifibrotic effects and the matrix metalloproteinase and reduction in inflammation. Before I conclude, I would like to stress that first you have to know that you cannot inject fat or stromal vascular fraction immediately in an infected wound. As my colleagues already mentioned, it's a teamwork. You have to first to clean your wound by any multiple sources that and things that you have, and then you can start your treatment with SVF, with enriched with insulin, with platelets, whatever. The chronic non-healing foot ulcer are increasing in prevalence, as you all know, and lots of them are not responsive to the conventional therapy. And here comes the role of the plastic surgeon to bring on the capability to enhance healing by soft tissue manipulation following a reconstructive algorithm to manage and salvage the diabetic foot ulcers. The factors that determine the success or failure of your treatment is the stabilization, the viability, the presence of comorbidities and medical condition, the elasticity and vascularity, leaving the limb in a stable, mechanical, and sound position. Adipose-derived stem cells is the future for regeneration and restoring not only the wound, but your whole body. Last year in the IFAT meetings, there were lots of, they show us how you can use it intradermally. Now they are using it even intramuscularly in an ischemic limb around the affected vessel. But I believe in few years they were gonna start to use it even intravenously, and the application is enormous. It's not only in soft tissue, it's in all the field of medicine. This is all what I have. Thank you for your
شكرا جزيلا لك سعادة الدكتورة ثريا طاشكندي على هذه المحاضرة القيمة والتي حملت كثير من المعلومات في تقنية الدهون والخلايا الجذعية، وهذه إضافة أيضا لهذه الندوة التي نقدمها في هذه الأمسية للحضور الكرام. ويمكن قبل ما أغادر معك دكتورة ثريا، معلش تصححي لي المعلومة، لأني أنا من الناس اللي عادة وأنا بحضر أي ندوة أو مؤتمر أتبحر شوية في مستر جوجل، أنكل جوجل، وأخش يمين ويسار، ووجدت معلومة تفيد بأن دكتورة ثريا طاشكندي هي الجراحة التجميل الأولى الأنثى في الشرق الأوسط. She is the first female plastic surgeon in the Middle East. لا أدري هل هذه المعلومة
جوجل كده يقول
صحيح المعلومة.
وهي موجودة في جامعة مكتبة الملك فهد.
حقيقة أنا سعيد جدا بمعلومة زي دي، إنها تكون اليوم بيننا أول جراحة تجميل على الشرق الأوسط، الدكتورة ثريا طاشقندي. بارك الله فيك وفي علمك وفي صحتك وشبابك دكتورة، بارك الله فيك، شكرا جزيلا. أنتقل الآن إلى المتحدث الأخير في هذه الندوة والمحاضرة الأخيرة، والتي تحمل عنوان تطبيق تقنية تترا سيلفر في منع البتر، الأمل عندما لا يكون هناك أمل. Application of tetra silver technology in amputation prevention, a hope when there is no hope. يا الله عليه من عنوان. What a title. I like it دكتور طارق. So giving hope to everyone, the hope when there is no hope. يسعدني ويشرفني أن أقدم المتحدث في هذه الندوة، في هذه المحاضرة، سعادة الدكتور طارق رضوان، وهو حامل شهادة ال FRCS Senior Consultant Vascular Surgeon at International Medical Center Cairo في المركز الطبي العالمي في القاهرة، ولدينا في جدة طبعا المركز الطبي الدولي، ونفسهم IMC. دكتور طارق رضوان is editor-in-chief of the Egyptian Journal of Vascular and Endovascular Surgery, and he is the Egyptian convener for Royal College of Surgeons of England for MRCS exam. Dr. Tariq Radwan is the president of the Egyptian Vascular Club. Welcome, Dr. Tariq, and you can share your presentation now. You will have 25 minutes from now.
Bismillah ar-Rahman ar-Rahim. I hope the screen is shared now. I got the title on the screen. That's right?
Yes.
Okay. First of all, I would like to thank this all panelists and organizing committee for this great webinar. I hope the audience are not so tired today. So I will try to make my presentation as light as I could. This my disclosure. I have nothing to disclose in this webinar. For introduction, because I'm from Egypt, I would like just to tell you something about the Egyptian history for diabetes, because the earliest known record of diabetes was written in a paper written by the great Egyptian physician Hisra in 152 before century, and he described diabetes as an frequent urination. 2 years later, in 1550 before century, the Ebers papers, and it is present in Saqqara pyramid till now, and it described diabetes as a too great emptying of urine. And adding to this, it describes some treatment for this, like drinking a mixture of old berry, milk, beer, swell, cucumbers, and green dates. So a long time ago, diabetes was known in Egypt. But what is the current situation? Unfortunately, Egypt is the 9th country with the highest number of diabetes worldwide. And diabetes affects 2.9 million, representing 15.2% of all adults in Egypt from 20 to 79 years. I actually admire much the presentation, the first presentation by Dr. Ashraf. I enjoyed it. And he described a lot about diabetes problem in the Middle East, in Saudi and in the Middle East. So, and amputation risk is the National Health Service in England reports that people who have diabetes are 15 times more likely to undergo amputation than other people. So for this amputation risk, amputation is the problem is amputation is also not a final step. What does this mean? I will show you two or three literature review, as Dr. Ashraf said, so I will not increase much, but this one was a nice literature review in 1917, and it shows that the mortality rate following amputation after 1 year reached up to 40%, after 3 years reached 65%, and after 5 years reached 80%. So you have to consider that 8 from your 10 people you do for them, say, below knee amputation, will die in 5 years. Also, this another a nice commentary review in 2020 in the foot and ankle in the Journal of Foot and Ankle Research, and it shows that the mortality of major amputation is comparable to lung cancer, and mortality of minor amputation is comparable to all cancers. So amputation, as I said, it is not the final step. Amputation is a start of having other problem. This also from the British Medical Journal is in 2020, and it showed a nice conclusion besides the previous mortalities rate that depression is a risk factor for this after major lower extremity amputation. And I think all the diabetologists know this. So depression is an adding factor. So by all this means, and because of this amputation risk, we have to do every effort to prevent amputation, and this is our work actually. We tried this in Egypt, and in the Vascular Society of Egypt, we tried to do more something like the Egyptian consensus 2015, and you can see Professor Mustafa is presenting today in the middle of this nice photo of Egyptian vascular surgeons. Also myself is here, and by this we put our Egyptian diabetic foot lesion management consensus to guide the trainee and the other surgeons in Egypt how to manage diabetic foot. Also in the International Medical Center, we tried to do what is called, I think it is known to my other presenters, but I'm directing this to our attendees, that we try to do the one-stop diabetic foot clinic, because one of our problem is the referral. Now, usually, when a patient comes to the hospital, and you can imagine this, if he come to my hospital and he asking to see a diabetologist, he will have an attendance or a visit after 2 weeks. And then the diabetologist will find that he has an ulcer, and a nasty ulcer, or something at risk, his foot is at risk, so he will refer him to us. So when he refer him to us, he might have another 2 weeks to see us. And then, so once you see the patient, might be after 1 month. So we try to put ourselves together in one place. So we did what we call the one-stop diabetic foot clinic as a one-shop visit, and this is known in many centers all over the world. So we can, by a multidisciplinary team, as my colleague said in the previous lecture, you can do the optimal glycemic control, effective local wound care, infection control, breathing relieving strategies by the flooding modules, monitoring and improving the vascular status by the vascular surgeons, patient indications by our specialized nurses. All of us work in one place, in one clinic, in one visit. And by this, we categorize our patients, and this also known worldwide, to 3 categories. And we use the light signals because it is known everywhere: red, yellow, and green. By the red, if the patient has ischemia and deformity and with previous ulcer, this patient is high risk food, and we should learn him intensified food care education. And we'll give him an appointment to see, as Dr. Ashraf said, after 3 months, every 3 months. And the at-risk food, which is the milder one with neuropathy and absent pulses, but no ulcers. So we teach him to enhance the food care education and ask him to visit us every 6 months. And the green one, who has normal sensation and palpable pulses. So we just teach him how he should care for his food. This is very important education, and ask him to visit us every 12 months. And by the end of the visit, we give him what we call the color-coded follow-up cards. You know, some of you know the hematology card. If a patient on anticoagulations and you need him to be followed up, this patient also has the three cards. He has one of this card inside his pocket, so he will remember every time he look at his wallet that he found the card that you should return to the hospital in your time. And I think this is very important for patients to be linked to a team to follow up them. Also, we give them some instructions for patients' education by our nurses, how to control the blood glucose, how he care for his food by printed publication. So the one-stop diabetic flu clinic improved a lot the management. It decreased the complication. It make communication between all the teams of the hospital. We learn from each other. If I'm besides the diabetologist, I'm besides the orthopedic surgeon, I'm besides the radiologist, we learn things from each other. And it is one-stop shop for the patient. So the patient is satisfied. We have direct referral, and we increase the profile of the hospital with this. And very important is, as other colleagues know who to refer this patient. Once he's seen a patient, he referred him directly to the clinic. So the diabetes wound care, we consider the time concept, which is something introduced 16 years ago. It is outside the scope, so I will not go through, but it gives you a structural approach to the wound bed preparation. It is a permanent reassessment about the tissue debridement, the inflammation, which is the infection, the moisture balance, and the epithelialization, and it is a continuous permanent reassessment. But what I want to say is that debridement is very important in your infected wound or diabetic wound, because once you have a big eschar or something, usually might be difficult to control your wound for fast healing. So if you could do debridement, you can do it. Debridement, you can do it surgical, biolytic, enzymatic, local, whatever the way, but debridement is the first step of your wound care. Also, the antimicrobial therapy, local antibiotics has no role in wound healing at all. Local antibiotics. Local antibiotics, you give it only in the spreading infection and systemic infection. So no need for antibiotics, either systemic or local, unless there is a spreading infection. I know Dr. Ahmed mentioned this in details, but I'll just summarize what is in the tetrasilver nanotechnology, why we use it, because it gives a wide antimicrobial effect against resistant bacteria, all the types of bacteria, fungi, and viruses. It has a high regeneration power by their action on stem cells, and it attacks the brain nerve endings. I will go rapidly because Dr. Mustafa actually showed us a lot of very interesting cases. So I will just show some of our cases. This is a case study and a rapid case of a 75 years old female diabetic. She's presented with an infected wound in the leg, coated with violet paint from use of topical antifungal for more than 4 weeks, and 3 types of systemic antibiotics with no result. This is first week. You have first to get rid of all these colors. So you have to wash this. I give her a chance 2 days to wash this. We take more showers to get rid of this violet color of the topical antifungal. Then we start to use the tetrasilver technology. This is the week 2, week 4, and week 5 complete healing. And this is the difference between the start and the week 5. Another interesting case, there is a 40-year-old gentleman. He is diabetic. His first presentation came to us 5 years ago presented with toxemia and gangrene of his left foot, for which we did for him an emergency through foot amputation because he was toxic. No thinking, you have to get rid of all the devitalized and gangrenous tissue, and then we managed by him by application of negative pressure wound therapy, and this healed. But second presentation 1 year ago, 4 years later, with the same condition but on the other foot, and we manage him with the same action through foot amputation and negative pressure wound therapy. This 1 year ago. Then third presentation 4 months ago, he came to us again as an emergency with uncontrolled diabetes and again toxic. And if you look how nasty is the lesion, he still have his forefoot amputation not properly healed. He's still under healing, but he have a nasty ulcer with extension of the gangrene to the forefoot and spreading infection up. And if you have a closer look, it is a very nasty lesion. And you might admire that we were in our early days, we used to hear this heal, never heal, heal, never heal. But in 2020, we should have an way that the heal should heal. So this we have to take him to theater because this is precious limb. His other limb has a forefoot amputation also. We need to do anything for him. So we did for him an extensive debridement on the second day straight away for admission. Still, he has a lot of necrotic tissue. I can't go more than this because the bone is nearly exposed. This is the day 2, some hope, but still necrotic tissue. So we started to apply the tetrasilver technology in him. This is the day 4 inside the hospital, the day 5 inside the hospital, and day 7 inside the hospital. Still, there is a minor necrotic tissues, but hoping granulating tissue coming to you. And then we discharge the patient and we start to follow him up weekly or every 2 other weeks with no antibiotics, just the tetrasilver technology applied, and we teach the patient how to use it. This is the week 3, week 5, very nice granulation. If you have a closer look, very nice granulation for him. Week 6, and this is how his forefoot looks like in the wound. And then his week 7, week 8, week 10, very nice granulating, week 12, and this also his forefoot, and this week 14, this is the last week. I hope this meeting was will be 1 month later. I will show you how his complete healing, but this only was last week photos, and this is the difference between his starting and after 14 weeks with no antibiotics, no negative pressure, only the tetrasilver technology. So we have to not need to continue or even do the skin graft for him. This is case study 3, another interesting one, 65 years old male. He just came to us very recent, diabetic, presented was infected ulcer in the foot, persistent for 3 months after incision in the drainage and excision of the metatarsal bone by his treating surgeon, but he had no response to many topical and systemic and treatments for 3 months with the same condition, and started to be disappointment. So we offered him to start him with the tetrasilver technology. We did for him the MRI and the foot, and this is a metatarsal bone exercise, a lot of rarification in the MRI. We put him in the tetrasilver technology, week 4, much improved, week 6, much improved, no antibiotics at all, week 10, and then this is the difference between week 1 and week 10. This was the last week. Another rapid case where a lady came with infected ulcer of the leg, nasty cross. We have to do the debridement. This is her first week after the debridement with application of the tetrasilver technology. Also in the week 8, very nice healing with no skin cover, or skin graft, I'm sorry, week 12 and week 16 nearly healing, and week 20 healed the leg and the foot is 90% healed, and I think it is healed now. And this week 24, this is the difference in her foot, nasty foot ulcer between week 1 and week 24. So in conclusion, my professors and chairmen established one-stop clinics improved the diabetic food services, understanding of the pathology and the nature of wound stage lead to proper treatment decision, fast healing, and avoids extra cost. And actually, Tetra Silver technology represents a major advance in diabetic food management. Now, because I'm a vascular surgeon and I'm interested in the endovascular surgery, so if anyone of you interested in the endovascular intervention, if you come to Egypt, you will see the Cairo Tower. This is built in 1960. And in the vascular surgeon, we don't call it Cairo Tower. We call it the largest endovascular stent in the world. Thank you very much.
شكرا لكم كثيرا سعادة الدكتور طارق رضوان. أخذتني الصور الجميلة حقت مصر، في الحقيقة ذكريات تعود إلى 3 عقود من الزمن أو 4 عقود من الزمن بيني وبين مصر، العشق الطويل الكبير، حيث أخذت شهادة البكالوريوس من جامعة القاهرة. حقيقة هذه كل الصور اللي حطيتوها ذكرياتها عميقة في قلوبنا ومحفورة في قلوبنا، وإن شاء الله تكون كورونا في عام 21 خفت وانتهت، ولنا لقاء هناك إن شاء الله، ويمكن نسوي ندوة في قلب القاهرة إن شاء الله، وعندكم في IMC في كايرو.
Inshallah, you are most welcomed, all the panelists and all the colleagues and presenters, because we enjoyed and take a lot of experience today from others.
نعم، ومعنا جميع الحضور الموجودين اليوم 1800 يحضروا معنا إن شاء الله نفس المؤتمر فيزيكالي حضوريا في القاهرة. يا رب، نقول يا رب
إن شاء الله.
أشكرك شكرا جزيلا دكتور طارق على هذه المحاضرة القيمة التي قدمتها. والآن مشاهدي الكرام، حان وقت المسابقة. وعدناكم بها من بداية الندوة، والآن أقول لكم أدخلوا على الشات وحتلاقوا رابط، اضغطوا على الرابط حينقلكم إلى استمارة المسابقة. حتجدوا 6 أسئلة بصيغة MCQ، عليكم إجابة جميع الأسئلة 6. سوف يتم إدخال جميع الإجابات الصحيحة للأسئلة 6 في تطبيق خاص بفرز الفائزين. بعد كده إن شاء الله الآن حنبدأ البانل ديسكشن for our second session، وخلال هذه الفترة الزملاء في الكنترول بيجهزوا تجهيزاتهم للإعلان عن الفائزين ال3 بعد جلسة المناقشة إن شاء الله. وأذكركم بأنه الفائز الأول حياخذ جهاز أبل آيباد، والثاني والثالث سوف يحصل كل منهما على سماعة أبل إيربودز برو. حظا سعيدا لكم جميعا. الآن نبدأ في الجلسة، جلسة المناقشة العلمية، ولا زال المايك معكم سعادة الدكتور طارق رضوان. وخليني أبدأ معاكم. وصل سؤال بيقول، وانتم بتتكلموا عن one stop clinic for the DFU, how the one stop clinic improves the diabetic food care?
Thank you very much. It is a very valuable question because it is some sort of practicing. As I mentioned in the lecture, before we established the one-stop clinic, we suffered a lot that myself as a vascular surgeon and I see a patient in a very late stage because he is circling between the whole clinics in the hospital, between the diabetic clinic, the orthopedic clinic, and because we are vascular surgeon, we see a lot of patients, not only with pure diabetic, but with ischemic diabetic foods. He needs assessment, he needs intervention, he needs angioplasty, he needs surgery, he needs something like that. So we sit together and we decided to do the whole clinics in one place. So in my hospital, I have in my clinic, in the vascular surgery clinic, I have a wide many rooms. So I invited all the other specialties to stay with us, and then we started with 1 day in the week. Once the patient come to say, I have a diabetes, I have a problem with my food, he will come to be seen by everyone. So consider that the patient will be seen by the diabetologist, will be seen by the orthopedic surgeon. He will have his duplex scan done. He will be assessed by us. He will have the offloading techniques. He has the orthostatic team present. He has the diabetology nurses present. And so the patient come after a long day, he nearly diagnosed, started the proper treatment. So I think many of the lesion which is supposed to be missed is involved by this technique.
I hope your answer is enough for that question. And I will shift to Dr. Suraya Tashkandi. How and where we inject the fat?
Accordingly where you want to use it. مثلا is in a diabetic foot, you insert it in the periphery of the wound, subcutaneously, sometimes even along the vessel of the, most probably there is a decrease in the blood flow, next to it intramuscularly.
جميل. طيب أشكرك وأنتقل إلى دكتور نشأت غندورة. Can we apply the amniotic membrane on an infected wound?
Thank you for your question, Dr. Abdel Hafiz. Actually, we are using diabetic food never to be a clean wound. Most of these cases, we have contaminated wound. You can say clean contaminated wound or contaminated wound. But in infected wound, I use it in one case, maybe the fourth case in the I show it to you, I show it in the slides. And at that time, this patient, you have to apply it again because the amniotic membrane already eaten by the infection. So after 2 weeks, I apply it again after cleaning the wound, also another session of the debridement. So I prefer to be in the clean or clean contaminated wound rather than in infected wound.
شكرا دكتور. بروفيسور مصطفى سليمان، أنا عندي سؤالين يمكن ورا بعضهم حيكونوا. الأول, what are the steps of dressing using tetra silver?
Hi, what can I do for you?
بروف الصوت. بروف مصطفى.
دكتور عبد الحفيظ يبدو انه عنده مشكله، البروف طلع وحيرجع.
طيب اذا عوده اليكم دكتور طارق. دكتور طارق رضوان, what is the best way to use tetra silver spray and gel?
If this not an advertisement, I will answer. Because
بنتكلم عن جانب علمي حقيقة.
Okay, all right. The best way, as we know from...
And again, I will tell, this medicine is approved from the Saudi FDA.
All right.
And it is available for use.
Okay, good. Now, the best way, as we know from the manufacturers, is we use both together. we don't use any other solution. Before that, we used saline, betadine, some nurse use hydrogen peroxide. We never used anything like this. We start with this, we spray the wound and we leave it for 5 minutes and then apply a very thin layer from the gel and leave it for 10 minutes to be absorbed and then cover by sterile dressing and cover the wound and we repeat this two times per day. This is the best way to use it.
شكرا. دكتورة ثريا, what are the common side effects in using fat injection?
That's what's nice about this technique. The side effects is you cannot lose anything. Either it works or it doesn't work, but it will, unless you don't use it, as I said before, you don't use it on an infected foot ulcer we are talking about, for example. You have to do debridement, you make sure that the necrosis is gone, and then you can use it. Either it works, I'm telling you, it will work, but if it doesn't work, there is no side effects, there is no problem in it. That's what's nice about it. There is no reaction. No, it's from your own body. It will not do any harm for the patient. You don't need to sterilize it, provided that you took it already in a sterile way and with a closed system, and you took all the measurements, and then you injected, you will have no problem whatsoever.
دكتور نشأت هنا سؤال عن الريجكشن.
عفوا دكتور عبد الحفيظ، البروف مصطفى رجع معنا الآن.
الحمد لله على السلامة.
أي نعم.
حياك الله بروف. بروف مصطفى سليمان.
مع حضرتك.
أهلا وسهلا، حياك الله عودا حميدا.
الله يخلي حضرتك.
ترى هذه حاجة كلنا بنتعرض لها، بنخرج ونرجع ثاني.
الحمد لله.
النت له دور، ترى اذا ضعف فجاه انقطع الاتصال فالواحد ريجكتد ويرجع ثاني ان شاء الله.
صحيح، برغم ان انا تخلصت من الاسره، تخلصت من الاسره كلها بره البيت.
يحرمنا منكم.
الله يبارك.
يلا يا سيدي، في سؤال بينتظركم.
اتفضل يا فندم.
What are the steps of dressing using tetra silver?
Yes. It's 3 steps. First thing, you wash the wound with distilled water and then wait for a couple of minutes and then spray the solution, the tetra silver solution. You spray it on the whole raw area and then wait for 5 to 10 minutes and then spread a very thin layer of the gel and then wait for another 10 minutes to dry up, and then either to leave it as it is or cover it with sterile dressings. But you can leave it exposed if it is a safe environment, no trauma and no infections, or if you are afraid, you can cover it with sterile dressings after 10 minutes.
طيب برضه في سؤال. أيوه.
About the frequency. It depends on the condition of the wound, either once daily or twice daily, depending on the condition of the wound.
في سؤال يمكن برضو مشابه. What are the usual dose of tetra silver solution and what are the contraindication to use it?
Yes. The dose, we said we put the spray 2 puffs on the raw area. This is regarding the solution. Regarding the gel, I mean you spread a very thin film over the whole raw area. This is regarding the dose. Regarding the contraindications, no contraindication at all. No contraindications. There is no allergy, no hypersensitivity, no interactions at all. It is a very, very safe material, and you can use it everywhere in the body. any wound at any area is permissible to be used. No contraindications at all for these products.
What are the success rate of using Tetra Silver in diabetic foot management?
Now, success rate from 90 to 100%. It's over for all me by all means. It is over 90%. It depends on the compliance of the patient and the other problems, medical comorbidities of the patient. If the patient is compliant and will go straight for the dressing every day, and the controlling every other comorbidities like diabetes, anemia, hypertension, etc., it will be very, very, very successful. As you see in my presentation, even if you have osteomyelitis, you can deal with it. Even you have charcot, you can deal with it. So success rate is very high unless you control the other more comorbidities.
Can Tetra Silver solution be given by diabetic foot specialist nurse, or should be by a surgeon?
No, I'll answer in another way. It can be used by the patient himself.
Ya salam.
It's very easy to apply, very simple dressing. So that's why I teach the patient himself how to use it, and he can use it at home even, and he just come for my clinic or for the hospital for follow-up on weekly basis, just to check the condition of the wound, and to, if we will do local injection, as you have seen in my presentation, we do it on a weekly basis.
شكرا بروف. بارك
Thank
الله
you.
فيك.
Thank you.
أعود إليكم دكتور طارق رضوان. In for the case 2, in your presentation, how far you use antibiotics and why you have not tried negative pressure wound therapy?
All right, thank you. It is a very good question. First part, how far we used it. This patient came with toxic and have a spreading infection. So we used it only as infectious diseases team. For us, they recommend between 5 to 7 days. So we just use it for the 7 days until the patient discharges, and then we stop the antibiotics. Why we haven't used the negative pressure? We have a problem in Egypt that negative pressure wound therapy is very expensive. If we use not the local manufacturers, but we use the international manufacturers, the two main companies for negative pressure wound therapy, it costs a lot in Egyptian money. And this patient tried this in post-forefoot amputation and post-limbs before. So the patient was actually coming, and once we told him that you could use the negative pressure, he refused. So we offered him, okay, so we'll use another technique and we'll try it because this coming with our first cases to use it. So he agreed, and the patient coming has negative feedback about the negative wound pressure treatment.
نعم. طيب أنا يعني يمكن ملاحظين إن أنا ما بذكر أسماء السائلين، لأني أنا بجمع يمكن سؤالين ثلاثة مع بعض وبطرحهم بصيغة واحدة وسؤال واحد توفيرا للوقت. ولكن أنا عندي سؤال هنا، والله أنا عجبني الاسم أكثر من السؤال. حقيقة اسم جميل جدا، نور الشهادة. هذا اسم السائلة، نور الشهادة سوبردي. جميل جميل جدا نور الشهادة. السؤال: how frequently, hi Dr. Tariq, and it is directed for you, how frequent the dressing of diabetic foot ulcer with Tetra Silver dressing?
We mentioned this, how frequent is we do it. I think the best way, I know Dr. Mustafa said some cases he will use it once, some cases will use it two, but my best results came with the use twice a day. Twice a day is the best results for any lesion.
جزاك الله خير، شكرا جزيلا. نعود إليك دكتورة ثريا، لو تكرمتي. what other applications for this mode, that is fat injection of treatment in medicine؟ نبغى نشوف الاستخدامات الأخرى.
There is a lots of what's nice of this international federation, it's not only for plastic surgery, it is for all fields of medicine. So people come from all over the world and they show their work using the fat and the stroma vascular fraction. But they used it in a patient, I cannot forget, the Parkinsonism and autism. They are using it in cardiac surgery, in neurogenic bladder, in the field of what they call it, nephrology, urologist, sorry. It's all in the field. طبعا in my field, in regeneration and cosmetic surgery, it's wonders.
Can you tell me about using of the fat injection in the joints?
Yeah, there is, as you know, Prof. Sabah and Dr. Amr Hibshi, they did lots of cases.
Encouraging?
Excuse me?
The results are encouraging?
The results are very, very encouraging, providing إنه البيشنت يعني حاجات they have to take it into consideration. مثلا مو patient she got the injection and after that she goes and gain مثلا 10 kilos or so, and then she will blame it on the stem cells. There are certain steps and points that you have to follow it. You have to reduce weight. You have to do some exercise, and you will get the great results. Lots of patients, even they are colleagues, they are doctors. They used to have terrible pain in the knee joints, and they are far much better now. I have, please.
أيوة.
For Dr. Sawah or Dr. Radwan, I wonder about the cost of the tetrasilver patches.
Can I answer this question?
If you please.
Yeah, you see, it is 120 gram per tube. It costs 320 riyal.
320 riyal?
20 riyal. Yeah, per 120 gram.
Yeah, and you are using how many tubes?
Use 3 to 4 grams for 10 by 10 wound. So it could last for 1 or 2 months.
So the total cost is how much for 1 or 2 months?
You are talking about 700 to 1,000 riyal.
Per month?
Yeah, no, for the 2 months.
700 riyal for 2 months?
Yeah.
The 2 months represent a full course?
Actually, it's according to the size of the wound. I'm talking about 10 by 10, cost you only 3 grams. This means that you have 40 applications for this size of wound. 40 applications, 40 days equal 320 riyal.
Okay.
And the spray is the same price as well. The spray is 326 centimeter or milliliter. So it stays even more than 2 months. It's very cost effective, by the way.
Yeah. Thank
you. شكرا دكتورة ثريا، بارك الله فيكي. والآن أنتقل إلى دكتور نشأت غندورة. أنا كنت بدي أسألك عن الريجكشن. Is there any documented cases with amniotic membrane rejection?
حقيقة دكتور عبد الحفيظ, I review also the literature. There nobody said there is any rejection because there is no, as I mentioned, HLA is negative. So it is no rejection. We can, in our cases, in our 68, there is no rejection, but maybe there is about 5% failure rates that the amniotic membrane not taken. Otherwise, from my experience, and I review the cases, there is no rejection. You can consider it in these procedures.
So my question, in case of failure, how many times you can use amniotic membrane on the same wound?
Actually, I have maybe in my hospital, we have 3 cases. We applied twice. Maybe one of these cases that with the infected wound, that one is not rejected. You can say there is infection, and that was mean the amniotic membrane is eaten already or dissolved. So no more. So I applied after 2 weeks. So it's very rare. You can consider it is only 5% or less than 5%. Your cases you have to apply it again. And as I mentioned, there is what you call it. There is selection patient criteria. Usually, as you can see in our patient, most of our patients, when I selected, usually the dorsum wound, and also you need also good patient compliance and close follow-up twice a week. You have to come to change the dressing, and also some cases I have to apply posterior slab, cast slabs to prevent movements in the joints, especially the ankle joints. This criteria is important to select it before you apply this amniotic membrane to have a good outcome. Alhamdulillah, as I mentioned, only about 95% the successful rates, and we have only 5% of the failure rates.
أشكرك دكتور نشأت. في الحقيقة الأسئلة كثير، ولكن إحنا أشرفنا على نهاية وقت الندوة. الآن اقتربنا من 10 إلى 3 دقائق، وسوف أكتفي بطرح سؤالين عليكم سعادة البروفيسور مصطفى سليمان كخاتمة لفقرة المناقشة العلمية، وننتقل بعد ذلك لإعلان عن الفائزين. يعني أنا متشوق أعرف مين اللي فاز بالجائزة الأولى بشكل خاص. Do you use other drugs with tetrasilver?
You mean the question must be more clear. You mean locally or systemically?
It is open. Let us take it locally, then systematically.
Okay, locally we don't use anything beside the tetrasilver except for the distilled water. Not even saline. We do distilled water just for wash, and then we use the tetrasilver material. Systemically, I give antibiotics and anti-inflammatory drugs if there is systemic or constitutional symptoms. If there is no systemic symptoms, we don't give any other drugs unless the patient needs something like for anemia or for immunity or for anything else, you can give. But I mean, for the care of the wound, nothing else than silver sol.
طيب كسؤال أخير، كل دواء وله الكونترا إنديكيشن حقته. ماذا عن السيلفر؟ Is there any contraindication to be given?
Not at all. Not at all.
Allah. That is enough. Thank you very much.
معلش دكتور فوجة، بس أعلق تعليق صغير الله يخليك.
اتفضل.
هو كلمة سيلفر كلمة عامة، في أنواع كثير من السيلفر لها آثار جانبية اللي هي قلناها الأيونيك مونوفالنت. أيوة. أما ما نعنيه الآن في محاضرتنا عن التترا سيلفر برودكتس اللي هو AG404 different molecular structure، ده اللي ملوش أي side effects.
Yes, my answer was concerning with the material I use, not silver in general.
Yes,
We
not
are
inhibitor,
using
of
the
course.
nano silver non-ionic structures.
ممتاز جدا. هذا الإيضاح جيد منكم سعادة الدكتور أحمد، بارك الله فيك. شكرا بروف مصطفى. الآن الكنترول عندي بيشير إنه لا زال يحتاج يمكن دقيقتين ريثما يتم الإعلان وتحضير الابليكيشن الخاص بفرز الفائزين.
طيب أنا عندي سؤال للدكتور
هذه
خوجة.
أي
هل إحنا ممكن نكون من الفائزين، يعني أسامينا في وسطهم ولا لا؟
أنتم الفائزون دوما بكل خير وبركة.
الله يبارك.
ونحن الفائزين بوجودكم بيننا.
هذا يكفي.
الآن طبعا عندنا
سؤال.
دقيقتين. يا دكتورة.
ممكن لدكتور نشأت.
أيوة.
ممكن أسأل سؤال لدكتور نشأت؟
أيوة هو موجود. دكتور نشأت.
دكتورة سوريا تفضل.
أبغى أسأل دحين إذا يعني you are getting your amniotic fluid from a patient طبعا عن الريسيبيانت صح؟ يعني
عيدي سؤالك يا دكتورة سوريا، عيدي سؤالك ما قطع.
الامنيوتيك فلويد اللي بتجيبها you are getting it from a different يعني donor غير الريسيبيانت.
بالضبط اكيد.
ايش الايم انتم حقكم؟ الستم سيلز that are in the amniotic fluids ولا the coverage itself ولا what? This is number one. Number two, you are not afraid of infection. Patient have undetected hepatitis, HIV, whatever. يعني I find very risky.
طيب شكرا جزيلا على سؤالك يا دكتورة سوريا. بالنسبة للسؤال الثاني، أبدأ بالسؤال الثاني. أنا في المحاضرة يمكن بينت إنه في عندنا criteria وبروتوكول you have to check for the seronegativity for the hepatitis C and hepatitis B and HIV and syphilis. And this one
window stage you cannot tell يعني.
Actually, we don't report any cases we get infection from the recipient and from the recipient. Hello? Yes.
أيوة سامعين.
سامعين. From the recipient and from the donors. So our protocol is very restricted regarding the seronegativity from even the donor. Regarding the first questions, we are taking the amniotic membrane. It's not the fluids, the membrane itself, the amnion. And this amnion usually, as you mentioned, just we have epithelial cells, cuboidal epithelial cells, which helping in the healing processing of that, but not the stem cells. As you know, the stem cells mainly from the spinal, from the what you call it, the umbilical cords. And from the placenta, I think, and also from the fat, from the bone marrow. We didn't talk about the stem cells from the amniotic membrane itself. إن شاء الله يكون جاوبت على سؤالك دكتورة سوريا.
لا للأمانة ما يعني ماني فاهمة أنا الأمنيوتيك
ممبرين في طبعا
عن أي كفرج ثاني. يعني لو أخذت أومنتم مثلا ما حيغطي، ما حيسوي نفس الشيء.
ما يعني يمكن هذا نكست ستيب نسويها.
ممكن قصدي أنا what I mean إنه what you are using the
amniotic membrane is covering the wound. You have to cover the wound from the infection. We are put amniotic membrane to cover the wound from the getting infection as you can and accelerate the healing process. It's accelerating the healing process.
Accelerated through what? Microscopic.
Through cytokine, through the interferon, through the as I mentioned the what you call it growth factors. All these the derivatives also. Material which are found in the human amniotic membranes. All this proceed helping in the accelerate this healing. أنا شرحتها في المحاضرة دكتورة سوريا، ما أدري أنت ما حضرتي شكلك المحاضرة.
لا حضرت.
على فكرة يا دكتور عبد الحفيظ، دكتورة سوريا يعني من أوائل الناس اللي ساعدوني في أول ما افتتحت الوحدة. حقيقة أنا أسميها بريف سيرجن. يعني حالات القدم السكري كانوا كثير من اطباء البلاستيك واطباء يمكن هذه كانوا يحاولوا يبعدوا عنها، خصوصا في حالات السكين جرافت والروتيشن فلابس. لكن عندي عده حالات اشتغلناها سوا، وما ادري ان شاء الله بتذكر الدكتوره سوريا. حقيقه يعني في مرضى كانوا فور بلو ني او اباف ني امبوتيشن، وبفضل الله ثم بفضل الجهود المتوافره عندنا في المستشفى والدكتوره سوريا ما شاء الله تبارك الله، نتائج جدا كانت رائعه. وفي لا زالت مريضه ان كانت تفتكريها اسمها فاطمه، هذه كل سنه من تتصل علي تعيد وتشكر، وطبعا اقول لها اذكر جميع الناس اللي ساعدوك في العمل.
الحمد لله.
جزاك
حقيقة
الله خير.
ذكريات جميلة، والله جميل جدا اننا نتكلم بهذا الكلام الجميل، والحضور معنا جالسين بيسمعوا. ترى هذه ذكريات، ترى احنا بنحمل في داخلنا ذكريات جميلة مع مرضانا بيعيشوا معنا. ترى احيانا ترى الجراح والله ليلة العملية بيحلم بمريضه وايش اللي بيصير، وبيخطط وبيقوم وما بينام، ويقوم في الصباح ويروح العمليات ويتوقع أشياء ويبدأ ينفذها. ترى في قصص كثير لو تقعدوا تسمعوا، يعني إيش العلاقة ما بين المريض والطبيب. العلاقة القريبة جدا، الكبير فهو أب، والصغير فهو ابن، والشابة هي أخت، وعلى كده.
دكتور خوجة ليا سؤال
جدا بيننا.
دكتور خوجة ليا سؤال للدكتورة سوريا.
اتفضل.
انا بس بسألها هي ازاي ساكتة على كده، وان يعني مرة يقولوا اول جراحة بلاستيك في السعودية، ومرة يقولوا اول واحدة تنشئ. بيكبروكي في السن ازاي كده يعني وانت ساكتة؟
اللفة وانا في اللفة.
انا يعني مش معقول.
ممكن انا اجاوب عنها؟
اتفضل.
ما يحتاج نتكلم، ما هي قدامنا موجوده.
ما انا عشان كده هي ازاي قابله انها يقولوا لها اول جراحه واول حد ينشئ وحده واول حد يشترك مش معقول كده. انا لو منك
في وجوههم،
انا لو منك اعترض اقول لا انا مش اكبر واحده في السعوديه ولا كده.
اكبر.
طب على فكره هي ما حطتها في السي في ده. انا
طبعا لازم.
انا بحثت وطلعت النقطه دي وجبتها معايا.
صحيح لازم كده.
طيب على العموم انا ادعوكم الان اننا فاصل قصير جدا ونعلن بعده الفائزين. فاصل قصير نشاهد فيه مقطع فيديو صغير.
بنسرع وقت الالتئام، بنمنع البتر.
الألم قل تقريبا من دي 1.
من أصعب الحاجات اللي ممكن تقابلنا في جروح القدم اللي هي جروح القدم السكري، لأن بيبقى المريض بيعاني من السكر وبيعاني من التهاب الأعصاب الطرفية، وكمان بيعاني من تأثير مرض السكري على شرايين القدم والأطراف السفلية.
أخيرا في السنتين اللي فاتوا دول ظهر تكنيك جميل جدا. التترا سيلفر تكنولوجي واحده من اهم التكنولوجيا اللي ممكن تساعدنا وبتفرق كتير عن التكنولوجيا اللي قبلها.
بتعمل مجال كهرومغناطيسي بيؤدي الى قتل البكتيريا،
بيقتل البكتيريا في مكانها بدون استخدام مضادات حيويه.
ليه قدره قويه جدا على اجتذاب الخلايا الجذعيه للجرح، فبالتالي بيحسن التئام الجرح.
تراكت الستيم سيلز والهيلينج باور، فبالتالي الريجنريشن باور بتاعه الوونز بيبقى ملوش مثيل.
احنا في الجرح اللي يهمنا الخليه لتكوين انسجه جديده، فالجرح يلم ويخف بسرعه، فبالتالي بدل ما الجرح يلم في 6 شهور يلتئم في خلال شهرين او شهر ونص.
تاثير السيلفر على الاستيميوليشن وللستيم سيلز ده قلل الالم.
قضينا على الميكروبات، قضينا على الالم، ساعدنا النمو، وحافظنا على انسجه الجسم.
كل الزملاء والجراحين والمرضى منتظرين حاجه زي كده، لانها فرقت كتير قوي في علاج القرح المزمنه بالذات.
النتيجه طبعا مبهره جدا. التكنولوجي ده احنا بنعول عليه بعد ربنا في نجاحات كثيره جدا جايه ان شاء الله في كل الجروح، وبالذات الجروح المستعصيه او الجروح التشالنجينج بالنسبه لنا.
قدر العيان يخرج البيت، بيخرج البيت بيوفر كتير من الهوسبيتال ادميشنز والهوسبيتال كوست، بيوفر كتير من استخدام الاجهزه. يبقى احنا بمركب واحد قدرنا ان احنا نستفيد كل الاستفاده، وادت معانا للنتيجه الكويسه.
ودي نتيجه نقدر نقول ان احنا غيرنا بيها مش بس حياه انسان، حياه الاسره كلها اللي كان مستقبلها هيتدمر لو الراجل ده اتعمل له بتر فوق الركبه.
في فرق كبير قوي ما بين المريض يقعد يعاني شهور يعالج قرحه في رجله، لا قادر يعيش ولا قادر يستمتع بحياته وبيخش في اكتئاب وممكن يوصل لبتر. فرق ان انا اوفر له الوقت من 6 شهور لشهرين، يعني للثلث، وبيرجع لحياته الطبيعيه تاني بدون اي مضاعفات.
التكنيك ده يعني اللي انا ارتحت له فيه انه بينقذ اطراف المريض من انها تروح.
إذا الآن حان وقت الإعلان عن الفائزين في مسابقة هذه الندوة. تم زي ما قلت لكم وضع جميع الحلول الصحيحة للستة الأسئلة في برنامج خاص بفرز الأسماء، يعني هو حيلف وحيوقف فجأة، ولا حيوقف عنده هو صاحب الحظ الفائز الأول. نبدأ بالفائز الأول، أتفضل. بسم الله الرحمن الرحيم. ها أيوة، بينكي. مين؟ علاء الدين النور. علاء الدين النور. ألف 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 مبروك للدكتور علاء الدين نور، وأنت قد فزت الآن بجهاز أبل آيباد. ألف ألف مبروك يا دكتور. الآن نبدأ بالفائز الثاني. يلا يا شباب. أيوة، أيوة حوراء علي القصاب. حوراء علي القصاب. ألف ألف مبروك يا حوراء. دكتورة حوراء، فزتي بأبل إيربودز برو سماعة. ألف مبروك. يلا نشوف صاحب الحظ الثالث. بسم الله الرحمن الرحيم. نوال. بس نوال ايه؟ نوال، هل هي واحدة متسابقة اسمها نوال فقط أم يوجد نوال أخرى؟
ايوه هي كاتبه اسمها كده.
هي الوحيدة نوال ولا في نوال أخرى؟ يعني هي الوحيدة اللي كاتبة نوال بدون أي لقب، وتقدروا تطلعوا تليفونها ومعلوماتها.
عموما دكتور عبد الحفيظ،
أيوة.
عبد الحفيظ، بالنسبه للفائزين نطلب منهم يا ريت رجاء لو انهم يرسلوا معلوماتهم بياناتهم على info@fexc2020.com.
ممكن نحطه على الشاشة يا شباب؟
يا فهد ممكن نحط الايميل على الشاشة اللي هو info@fexc
ايوه 2020.
2020.com.
بس أنا لا زال سؤالي مع الأخت ليلى. يا أستاذة ليلى، اللي اسمها نوال هي الوحيدة اللي كاتبة نوال بدون لقب، وتقدروا تطلعوا معلوماتها؟
بنشوف إذا نقدر نوصل الإيميل ونسألها نتأكد من بياناتها الشخصية.
إيميلات، تليفونها مسجل؟
مع انه منبهين احنا انه الكل يسجل بالاسم الثلاثي الكل، ولكن هو عموما اي واحد موجود من الاخوان اللي موجودين وجاوبوا هو اوريدي مسجل عندنا في الزوم، وبالتالي حنعرف مثلا نوال مين ونقدر نعرف.
على العموم هي شكلها ما كانت متوقعة انها حتفوز، والا كانت كملت اسمها
والا كانت كملت الاسم
8.
بالكامل.
ولكن هي صاحبة حظ. الف مبروك لك يا اخت نوال، يا دكتورة نوال، لانه جميع الحضور هم
المفروض انه
اطباء اللي
جميعهم
عندنا.
اطباء او ممارسين. نعم.
وممارسين صحيين. الف مبروك لك، فزتي بابل ايربودز برو سماعة. الان وقبل أن نختتم الندوة، أدعو رئيس اللجنة العلمية ليلقي كلمة ختامية للإخوة الحضور وللسادة المتحدثين في الندوة. سعادة الدكتور أشرف أمير.
دكتور عبد الحفيظ، جزيل الشكر لك لهذه الفرصة أنه يعني يكون لي مداخلة على نهاية هذا اللقاء الجميل. حقيقة أود أشكر الحضور الغفير، ما شاء الله تبارك الله، من الزملاء والزميلات من أصحاب التخصصات المختلفة، لكن في النهاية تصب في مصلحة أعتقد هي مهمة جدا في خدمة مريضنا مريض السكري، وبالذات في رعاية وعناية القدم السكري. طبعا أنا كنت متابع خلال الفترة هذه، وكنت أستمتع جدا بالتعليقات والانطباعات الرائعة عن جودة المخرجات العلمية لهذا اللقاء، فهذا شيء جميل جدا، وهذه كانت يعني التعليقات المتكررة باستمرار. ذكروا من حيث التنوع في المحاضرات وتميز المحاضرين. كل الشكر والتقدير لكل زملائي وأساتذة المحاضرين، حقيقة تعلمت منكم الكثير اليوم. الشكر كمان موصول لشركة عناية الراعية لهذا اللقاء، فشكرا جزيلا لكم. وحقيقة أحب أعبر عن نفسي، استمتعت كثير بهذا اللقاء العلمي الثري. كل دقيقة حقيقة تعلمت منها الكثير، وأنا على هذا القدر من الشغف الكبير لتعلم المزيد. وإحنا هذه طبيعة حياتنا المهنية الطبية في مجال الطب، في كل يوم نتعلم. مدرستنا الكبيرة هي مدرسة الحياة، ومدرسنا الحقيقي هو مريضنا الذي بيجلس أمامنا. كل يوم نتعلم منه الكثير، هو المحفز لنا للتعلم الكثير. كل هذه المقدمة لن أغفل عن شيء مهم جدا لابد أني أذكره. أود يعني حقيقة العاقب على الموقف اللي طرأ في منتصف الجلسة الأولى. أعتقد أنه موقف يعبر عن رأي شخصي وموقف فردي، لكن في النهاية يبقى الاحترام والتقدير والسلوكيات اللي تربطنا مع بعض في مهنة الأخلاقيات والإنسانية، هي مهنة طبنا العظيمة، مهنة الطب العظيمة اللي احنا كلنا نمتهنها، وبالتالي تحكمنا في إطار أخلاقيات واحترام وتقدير الجميع. نيابة عن اللجنة المنظمة واللجنة العلمية اللي أنا أرأسها، أتوجه لسعادة الدكتور أحمد السواح بالاعتذار الشديد، ومنا كل الاحترام والتقدير لشخصه الكريم. ختاما، إخواني أخواتي زملائي زميلاتي، أتمنى أن نكون وفقنا في تقديم قيمة مضافة تثري واقعنا العملي في رعاية مرضى السكري والحفاظ على سلامة وأمان القدم السكري من البتر. طبعا استعراض كل المستجدات الحديثة والجديدة في مجال علاج القدم السكري. لكم مني جميعا كل الاحترام والتقدير والتمكن والتمكين، ودمتم جميعا بخير وتميز بإذن الله. والشكر لكم جميعا، وتصبحون على خير.
شكرا لكم سعادة الدكتور أشرف أمير. وإذا كان لي كلمة فليست لي، فهي من اللجنة المنظمة لهذه المناسبة العلمية الكبيرة. أشكر من خلال اللجنة المنظمة للندوة مؤسسة ملتقى الخبرات لتنظيم المعارض والمؤتمرات على تنظيم لهذه الندوة العلمية، ويكفينا ما وصل من عبارات الشكر والتقدير والامتنان عبر الشات لهذه الندوة. أخص بالشكر أخي الكريم سعادة الأستاذ حسن البهكري المدير العام لهذه المؤسسة، وأيضا جميع أعضاء فريق العمل معه في إخراج هذه الندوة بهذه الصورة وهذا الشكل الذي شرفنا جميعا. أشكر السادة المتحدثين في الندوة حسب ترتيب محاضراتهم: سعادة الدكتور أشرف أمير، سعادة الدكتور أحمد السواح، سعادة الدكتور خالد إدريس، سعادة البروفيسور مصطفى سليمان، سعادة الدكتور نشأة غندورة، سعادة الدكتورة ثريا طشكندي، سعادة الدكتور طارق رضوان. كما نشكر الشركة الداعمة للندوة وهي شركة عناية الطبية. نشكر كافة الوسائل الإعلامية الإذاعية والصحفية المقروءة والمسموعة ووسائل التواصل الاجتماعي الذين ساهموا معنا في تغطية هذا الحدث من قبل أن ننطلق به في هذا اليوم المبارك. وأخيرا الشكر كل الشكر لكم أنتم حضورنا الكرام على تلبيتكم دعوتنا، شرفتونا بوجودكم، أمتعتونا بوجودكم ومتابعتكم. أبشركم بأن الساعات العلمية المعتمدة من الهيئة السعودية سوف تضاف تلقائيا إلى حساباتكم اعتبارا من يوم 20 من شهر يناير الجاري. أبارك للفائزين: الدكتور علاء الدين نور الفائز الأول، الدكتورة حوراء علي القصاب الفائزة الثانية، الدكتورة نوال الفائزة الثالثة. متعكم الله جميعا بالصحة والعافية والسعادة، والسلام عليكم ورحمة الله وبركاته.
عليكم السلام ورحمة الله وبركاته.
السلام عليكم.